Hello students, good afternoon everyone. Can you hear me? Good afternoon everyone. Am I audible? Am I audible? Please give me a thumbs up. All right. So continuing from yesterday's session, we were supposed to complete RBCs and WBCs yesterday, but due to some technical glitch, we had to stop, and we'll be continuing from yesterday. So we'll be continuing with thalassemia. Thalassemia is the next set of hemoglobinopathies. What did I tell you? Hemoglobinopathies can be quantitative or qualitative. Qualitative means we studied about the hemoglobin defect. That was sickle cell anemia. Now we'll be covering quantitative. We will be covering quantitative defect. Okay, quantitative defect, that is popularly known as thalassemia. Thalassemia, we have two types. All of you know alpha thalassemia and beta thalassemia. Beta thalassemia again is divided into major, intermediate, and minor. Starting with, okay, alpha thalassemia, please note alpha thalassemia defect is because of the gene deletion. Where do you find which is the gene for chromosome for alpha thalassemia? Sorry, which is the chromosome for alpha gene? Can anybody tell me? Chromosome for alpha gene is your chromosome 16. However, for beta gene, it is chromosome 11. And please note, in alpha thalassemia, there is a gene deletion. And beta thalassemia, there is point mutation of the beta gene. Okay, coming to alpha thalassemia. We all know there are two pairs of alpha genes. Two pairs of alpha genes who are found in the mother and two are found in the father. So deletion of gene. That's what I told you. Alpha thalassemia is deletion of gene. So basically depends how many genes are deleted. See, two pairs, alpha gene. If one gene is deleted, the patients are normal, asymptomatic. They are called silent carriers. If two genes are deleted, could be from one parent or one from both the parents. This is thalassemia trait. Okay, and this type of gene deletion is known as cis deletion or trans deletion. So one gene deleted, silent carriers, two gene deleted, trait, three gene deleted. If three alpha chains are deleted, what will happen? The beta genes, the beta chains, they will aggregate and form beta 4 tetramers. Okay, they will form beta 4 tetramers, and this is known as hemoglobin H disease. And characteristic appearance that you see in HbH disease is golf ball appearance. I'll just show you the figure for golf ball in HbH disease. Now, all the alpha genes are deleted. This case is incompatible with life. There is intrauterine death. And what happens? There are no alpha chains. What will happen in the fetus? Gamma 4 tetramers will be formed. Why gamma 4s? Remember, fetus HbF hemoglobin HbF is made up of alpha 2 and gamma 2. When alpha 2 is not there, alpha chains are not there, gamma tetramers will be formed, and this is known as Bart's disease and a common cause of non-immune hydrops fetalis. Okay, common cause of non-immune hydrops fetalis, right? Okay, so this is the golf ball appearance that I was talking about. Golf ball appearance seen in HbH disease. Okay, HbH disease because of beta 4 tetramers. Okay, beta 4 tetramers. Now, these are your cells with beta 4 tetramers looking like a golf ball. See, these dots that you have in a golf ball, just like this, the cell appears. Okay. And what is the stain that we are using here? We are using And what is the stain that we are using here? We are using supravital stain. Okay. Supravital stain. All right. So this was HbH disease, 3 alpha chains deleted. Now, on electrophoresis, what will you see in alpha thalassemia? Remember, we are talking about alpha thalassemia. What will you see? Silent patients, 1 gene detected, electrophoresis will be normal. 2 genes related trait HBR, then you will find HB bar, but it will be small amount which will disappear in adult life. And your HbA2, what was the normal HbA2 level? It was less than 3.5, 2.5 to 3.5. So HbA2 would be normal or slightly reduced here. Remember, I will ask you this question again once we are doing beta thalassemia trait. Alpha thalassemia trait, HbA2 would be normal or slightly reduced. Okay. HbH disease, your HbA, HbA2, HbF would be reduced wherever you get alpha chains in your hemoglobin. All these hemoglobins will be reduced. HB bar, all these hemoglobins will be absent because there is no alpha chain, right? All these hemoglobin will be absent. You will see HB bar 80 to 90%. You will also see HBH and HB Portland. So this was alpha thalassemia, right? Now coming to beta thalassemia. Beta thalassemia, also known as Cooley's anemia. We all know about it, or Mediterranean anemia, right? Mediterranean disease, sorry. Complete deficiency of beta chain is represented as beta 0. Partial deficiency is represented as beta plus. All right. Now, common beta thalassemia mutations that we see in India are these. Please note, these have been asked never in your NEET PG, but I said they have asked, especially this mutation. Okay. So these mutations, common beta thalassemia mutations that are usually seen in India. All right. Okay. Now, beta thalassemia, we all know, divided into beta thalassemia major, intermediate, and minor. Beta thalassemia major, when both the beta genes are deficient, that means it is a homozygous. One partially deficient, one completely deficient, it is heterozygous. So this is homozygous. This is heterozygous. Okay. Right? So beta thalassemia major, these patients are also called transfusion dependent thalassemia, right? Because these patients, for their complete life, they depend on transfusion. Then thalassemia intermediate, they are non-transfusion dependent, and thalassemia minor patients usually have anemia or are usually asymptomatic or might be detected once they are being evaluated for iron deficiency anemia, because the blood pictures, the peripheral smear quite overlap. So they usually get detected when they are being evaluated for iron deficiency anemia. All right. Okay, coming to beta thalassemia major. Beta thalassemia major, the exact pathogenesis, what occurs, there is deficiency of beta chain, right? Beta gene chromosome 11, remember. Alpha gene chromosome 16, beta gene chromosome 11. So beta chain is deficient. There would be an imbalance between your alpha and beta chains. What will happen? Beta chains are less, so there would be alpha inclusions in the RBCs. Alpha inclusions will lead to ineffective erythropoiesis, which will in fact lead to anemia. Okay, this would lead to anemia. Because there is anemia, there would be increased erythropoietin secretion. There was a negative feedback. RBCs are less, erythropoietin secretion will be more. So bone marrow will start overproducing your RBCs. So what will happen to bone marrow? The bone marrow expansion will occur. This explains your skeletal changes that you see in beta thalassemia. All right. So bone marrow expansion because of increased erythropoietin, and because of increased erythropoietin, extramedullary hematopoiesis will also start. Extramedullary, where does extramedullary hematopoiesis occur? Spleen, liver, and this will result in hepatosplenomegaly. That is why you will see extravascular hemolysis in beta thalassemia. Also, we studied yesterday in iron deficiency anemia because of increased erythropoietin. What happens? Hepcidin level decreases. Hepcidin level decreases, so iron absorption would be less. Iron absorption would be less. This iron that is normally present in your diet, not deficient, this iron will get stored and you will have in iron overload. This will lead to secondary hemochromatosis. Cardiac failure is the most important cause of death in patients with secondary hemochromatosis. And also, in these patients, there would be multiple blood transfusion. This will also lead to secondary hemochromatosis. I hope you are able to understand the pathogenesis of all the clinical features that we see in beta thalassemia. So because of ineffective erythropoiesis, what do you see? You see hair on end appearance. Okay. Crew-cut skull. Crew-cut skull. Hair on end appearance. And the typical faces that we observe is chipmunk faces. Now, this is the blood picture. Remember, we had studied microcytic hypochromic anemia. Sita mnemonic. Sita was sideroblastic iron deficiency. T was thalassemia. Then this is anemia of chronic disease. Okay. Now, for the blood picture of thalassemia, remember thal. Thal. What do you mean by thal? Target cell. And can anybody tell me what do you see in this peripheral smear? You see target cells. You see Howell-Jolly bodies. You see anisocytosis. You see low MCV. Okay? So thalassemia के लिए just remember target cell, Howell-Jolly bodies, anisocytosis, low MCV. And what do you see in this peripheral smear? Can you see the target cells here? You see marked anisocytosis, microcytic cells, hypochromic cell, different shape. Okay. And plus microcytic, so MCV would be low. Now, what do you know about Fessa's body? Can anybody tell me what is Fessa's bodies? See, beta thalassemia, your beta chains would be deficient. What will happen to alpha chains? वहां पे alpha thalassemia में we studied about the beta 4 tetramers and the gamma 4 tetramers. So here what will form? Here your alpha chains would aggregate. Okay. So alpha chains would aggregate in the peripheral RBCs. These cells are known as Fessa's bodies. These aggregates are known as Fessa's body. So I hope beta thalassemia clear. Now, target cells, we've been talking about target cells. Target cells also known as podocytes. Target cells, just like your bullseye. You have an outer stain, the cell stains outer and inside central. What is the mechanism for target cell formation? See, there is increased surface area, reduced volume of the cell. Why? Because hemoglobin is less. So reduced volume, this basically results in central pooling of the hemoglobin. Central pooling of the hemoglobin, that is why the stain is taken up here. This gives the appearance of target cell or bullseye appearance, podocytes. Now, for target cell, remember a very sweet mnemonic, hot lips. Hemoglobinopathies, where do you find target cells? Hot lips. Hemoglobinopathies, obstructive jaundice, thalassemia, liver disease, iron deficiency, we've already seen it, polycythemia, and sideroblastic anemia also. So these are the places where we find target cells, right? Now, what will you see in hemoglobin electrophoresis? Hemoglobin electrophoresis, you will basically see your hemoglobin A is reduced. Why? Because your beta chain is reduced. So hemoglobin A would be reduced, but on the other hand, There are no beta chains, so hemoglobin, the alpha chains will bind to your gamma chains. So your HbF will be markedly elevated. Okay, HbF. So if this is a normal electrophoresis pattern, your HbA2 is this much, HbF is this much, and the major portion is HbA. This is usually less than 3.5. HbF is less than 1%. HbA, the normal is 95 to 98%. Okay. What happens in beta thalassemia? Beta thalassemia, your HbF would be markedly raised. HbA would be reduced. And you can also see small amounts of HbA2, right? So, but please note, if you've been asked what is the confirmatory test, it is not electrophoresis, it is high performance liquid chromatography, HPLC. So, the confirmatory test for thalassemia is HPLC, right? Okay, now coming to beta thalassemia minor. Minor में first test, what do we do? Osmotic fragility. Although not done these days, but osmotic fragility, remember hereditary spherocytosis में the curve shift towards right. What happens here? The curve shift towards left. Okay, there is a shift towards left. Why? Because the cells here are tough. Spherocytosis में because of the membrane defect, the cells were weak. Here the cells are tough and the curve shifts toward the left. Okay. Then electrophoresis in beta thalassemia minor. Please note the characteristic or the characteristic finding here is HbA2 would be more than 3.5%. There is no other disease where HbA2 is raised from its normal level, more than 3.5%. Only in beta thalassemia minor or intermediate, your HbA2 would be increased. See, here HbA2 this is your HPLC, HbA2 is increased, HbF is definitely going to increase, but HbA would be markedly reduced. Okay. Now, coming to Menser index. Okay, we all know microcytic hypochromic anemia. How will you differentiate the overlapping features? You see the same, almost the same features in peripheral smear of iron deficiency anemia, also same features in your beta thalassemia. So what is how do you differentiate iron deficiency from thal minor? You do the Menser index. Can anybody tell me what is Menser index? How do we calculate? Menser index is equal to, yes, MCV upon RBC. Okay. In thal minor, this value is less than 13. Whereas in iron deficiency anemia, this value is more than 13. Now, can you correlate why is the value more than 13 in iron deficiency anemia? Why? Because there the RBC value is low. Denominator is low. I'm sorry, I just touched something. Minor, this value is less than 13. In iron deficiency anemia, this value is more than 13. Why is iron deficiency anemia value more than 13? Why? Because there the denominator RBC production is relatively less than thalassemia minor. Why? Production. I'm talking about the production. I'm not talking about the levels here. Thalassemia minor, there is increased RBC production. Why? First of all, there was erythropoietin stimulation. Okay. Even though RBC production, there is ineffective erythropoiesis, but RBC production is relatively more. Iron deficiency anemia, you don't have the raw material, iron. So your RBC production would be less there. Okay, so that is why denominator is more. That is why your Mensa index is less in Thal minor. Okay, clear? Now, coming to, these were hemoglobinopathies, coming to the acquired hemolytic anemias. We've studied about the hereditary hemolytic anemias, now the acquired hemolytic anemia. We usually ask about paroxysmal nocturnal hemoglobinuria. Okay, paroxysmal nocturnal hemoglobinuria is an acquired chronic intravascular hemolysis activated by complement system due to a defect in the red cell membrane. I hope you remember the figure of the red blood cell that we studied yesterday about the hereditary hemolytic anemias and the acquired hemolytic anemias. All the hereditary hemolytic anemias were because of the defect in the red cell, either the membrane or within the cell, the enzyme or the hemoglobin. Acquired hemolytic anemia, there was something coming from the outside. But paroxysmal nocturnal hemoglobinuria is the only acquired hemolytic anemia with a membrane defect. Okay, with a membrane defect. This was coming on this side of the figure, but it's an acquired hemolytic anemia, but with a membrane defect. But what is the defect? There is mutation in the X-linked gene PIGA, which leads to deficiency of your GPI anchor protein. Okay, GPI anchor is there on the red blood cells, and the proteins associated with it are DAF, decaying activating factor, CD55 or CD55, and MIRL and CD59. Okay, because of this deficiency, there is complement mediated intravascular hemolysis. All right. So the screening tests that we use are Ham's acidified serum test, sucrose hemolysis test, gel test. These are the screening tests. The confirmatory test here is flow cytometry. Flow cytometry plus we use FLAIR also. What is flow cytometry? Flow cytometry basically measures the CD55 or CD59, your DAF or MIRL. Okay. Whereas FLAIR, what is FLAIR? FLAIR is fluorescently labeled aerolysin. This tests your GPI anchors on the cells. Okay, this tests your GPI anchors, whereas flow cytometry measures your anchored proteins, GPI anchored protein. If they are asked which is the one confirmatory test, that is your flow cytometry. Okay, flow cytometry is the confirmative test. Now, coming to a question quickly that was asked last year in NEET PG, which of the following statements about PNH is correct? It's an inherited disorder? No. Although there is a genetic mutation, but that mutation is acquired. Okay, this is wrong. It is a leading cause of death in anemia-related heart failure? Again, no. Flow cytometry is the gold standard for diagnosis. Yes, flow cytometry is the gold standard for diagnosis. Sucrose lysis test is a screening test. Okay, so this was about paroxysmal nocturnal hemoglobinuria. Then one more cause, mechanical trauma due to the microvasculature. Something outside, some external factor is causing trauma to the microvasculature. What is the term we use? What type of anemia? Microangiopathic hemolytic anemia. It could be due to an external impact. Remember the marchers, anemia found in marchers, joggers and marchers. Then cardiac hemolysis because of the prosthetic implants. Because of the implants or because of the pacemakers, they can cause cardiac artificial valves also, they can cause cardiac hemolysis or fibrin deposit in the microvasculature. like in thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, HELP, DIC, vasculitis, or malignant hypertension. All of them can cause mechanical trauma to the microvasculature. Now, what do you see here? You see schistiocytes. Schistiocytes? Schistiocytes are basically fragmented red blood cells. If you see, these are fragmented red blood cells. Because of the trauma, because of the shear stress of the flow, there is trauma to the RBCs. Next, what do you see? You see Burr cells. What is the other name for Burr cells? That is echinocytes. Okay, echinocytes. And you can also see some helmet-shaped cells. These are called helmet cells. These are your Burr cells or echinocytes. All right. Now, we're giving you this blood picture. An adult male with abdominal distension, chronic diarrhea, visual disturbances, and neurological deficit. Based on the characteristic finding on the peripheral smear, what is the most likely diagnosis? Now, I told you earlier slide, we saw echinocytes or Burr cells. But what are these cells? Will you call them echinocytes? What will you call them? Echinocytes. Echinocytes had regular spikes on the cells. These are irregular projections. So what are these called? These are called acanthocytes. Okay, acanthocytes or spur cells, right? These are called acanthocytes or spur cells. So where do you find acanthocytes or spur cells? Characteristically, you will see in A-beta lipoproteinemia. Okay, A-beta lipoproteinemia. All right, understood? Moving on to the next. Acanthocyte and echinocytes are difference. Acanthocytes, I already told you, spur cells. Echinocytes are Burr cells. The projections are irregular of various length and are unevenly distributed. Whereas in echinocytes, they are regular, short, uniform, evenly distributed projection across the entire cell surface. Central pallor is absent here. It is present. Acanthocyte, irreversible. Remember, irreversible. And this is often reversible. Okay, how will you remember? Right. Just remember psi Burr. Okay, psi Burr. Psi, how do we pronounce it? Psi. So that is spur cells. A is acanthocytes. I is irreversible or irregular. Okay. Psi, spur cell, acanthocyte, irreversible, irregular. Then Burr के लिए B is Burr cells, E is echinocytes, R is regular or reversible. I hope you will be able to remember by this what is the difference between acanthocyte, spur, irreversible, echinocyte, Burr, reversible and regular. All right. Now, very quickly summing up, where do you find extravascular hemolysis? Where do you find intravascular hemolysis? Extravascular hemolysis, hereditary spherocytosis, sickle cell anemia, thalassemia, autoimmune hemolytic anemia, in warm autoimmune hemolytic anemia, and cold agglutinin disease. On the other hand, intravascular hemolysis seen in microangiopathic hemolytic anemia, paroxysmal cold hemoglobinuria, ABO mismatch, drugs, and certain infections. Only G6PD deficiency, we can have both extra as well as intravascular hemolysis. All right. Now, coming to aplastic anemia. Aplastic anemia, what do you find? Pancytopenia. The bone marrow shuts down. There is no work, no work going on in the bone marrow. So there is pancytopenia. There's anemia, leukopenia, thrombocytopenia. All the three cell lineages are affected. Inherited causes, acquired causes, you can learn these. Then what do you see? Even the reticulocytes would be absent. Why? Because there are no newly released cells, RBCs being released. So even the reticulocytes would be absent. there would be leukopenia, thrombocytopenia, bone marrow aspiration, you will get a dry tap. Why? Because there are no cells. You will get a dry tap. Bone marrow biopsy, you will be hypocellular or acellular. Okay. Plus, please note CD34 would be negative. CD34 is a marker for your hematopoietic stem cell. Progenitor cell, it will be negative. And also splenomegaly would be negative in patients with aplastic anemia. If you get pancytopenia with negative splenomegaly, it cannot be, if you get pancytopenia with positive splenomegaly, a patient comes with splenomegaly and pancytopenia, that can never be aplastic anemia. You will have to rule out some other cause. Aplastic anemia cannot occur in the presence of splenomegaly. What is the diagnostic criteria for severe aplastic anemia? Your bone marrow cellularity should be less than 25%, plus at least 2 or more than 2 of the following features should be present. Your absolute neutrophil count less than 500, platelet count less than 20,000, and corrected reticulocyte count less than 1%. Bone marrow cellularity less than 25% plus any of the two of these features. Very severe aplastic anemia is your neutrophils would be less than 200 per microliter. Okay, this was all about RBCs. Now let's start with WBCs. Okay, WBCs, I will first quickly discuss the congenital WBC disorder. First of all is the Alder-Rayleigh syndrome. Alder-Rayleigh syndrome, please note, it's an autosomal recessive disorder associated with mucopolysaccharidosis. What is the defect in the granulocytes? You will see large azurophilic, basophilic, metachromatic granules. Okay, large granules. Then see, this is the WBC, large metachromatic granules that will be visible. And what is the characteristic feature that you see in lymphocyte? Lymphocyte, what is the lymphocyte is called? The Gasser cell. Basically, in the lymphocyte, you will see cytoplasmic vacuoles, right? Cytoplasmic vacuoles, sometimes vacuoles or sometimes comma or dot-shaped structure. If you see this lymphocyte, these are the cytoplasmic vacuoles. Sometimes you can even see a comma or a dot-like structure. These are called your Gasser cells, seen in Alder-Rayleigh syndrome. Next congenital defect is Shediac-Higashi syndrome. Again, it's an autosomal recessive disorder. The defect here is Lys gene defect. What do you see? Giant granules. Plus, there's partial albinism, silvery hair. The patients will present with albinism, silvery hair, photophobia, recurrent infection, and increased bleeding tendency. How will you remember Chediac? Just remember the features of Chediac. Just remember the word Chediac. Chediac is C. CNS defects. You will also see hemorrhage, decreased immunity or infections. Then you see albinism. And then you see coarse granule. K ka C, coarse granules. Okay. These are seen in Chediac-Higashi syndrome. Right? Now, coming to May-Heglen anomaly. May-Heglen anomaly, what do you see? You see giant platelets with few granules. Giant platelet with few granules. But what is the defect that you see in the WBC neutrophil? What you see? Dole-like bodies. Not the Dole bodies, which is the normal. You see Dole-like bodies. Basically, these are clumps of Dole-like bodies are clumps of ribosomal RNA. Okay, ribosomal RNA. What are the Dole bodies made up of? Can anybody tell me what are the Dole bodies made up of? They are made up of dilated endoplasmic reticulum, and they're usually seen in the periphery. Okay, usually seen in the periphery. This is not seen in the periphery. So this is May-Heglen anomaly. Now coming to leukemias. We have acute leukemias or chronic leukemias divided into acute or chronic, and then myeloid or lymphoid. So the 4 leukemias that we are going to study about will be the AML, CML, ALL, and CLL. Right? So acute leukemias, of course, divided into AML and CML. First, let's quickly revise the differences between a myeloblast and the lymphoblast. The characteristic feature that differentiates myeloblast, lymphoblast apart from the chromatin and the nucleoli. More number of nucleoli in the myeloblast, 2 to 5. Less nucleoli in the lymphoblast. The characteristic feature that you see in myeloblast are the OR rods. Okay, these are the OR rods that are seen in myeloblast, not in lymphoblast. And myeloblast stain with MPO, Sudan, NSC. These are the immunohistochemical stains for myeloblast. Lymphoblast, fast stain, and acid phosphatase. Okay, acid phosphatase, right? Now, acute myeloid leukemia, I'll go very quickly. We know about the FAB classification, we know about the WHO classification. There is no role of viruses in the causation of acute myeloid leukemia. There is oncogenic mutation, some risk factors. What are the risk factors? Remember, my radiologist uses chemotherapy. My radiologist uses chemotherapy. MICA is MDS. Radiation, unknown genetic defects, and chemotherapy. So these are the risk factors for acute myeloid leukemia. Okay. Now we'll study the FAB classification. If you are done with FAB classification, WHO classification would be much easier. FAB classification, M0, minimally differentiated AML, more than 20% blast. For an acute myeloid leukemia, you have to have more than 20% blast expressing myeloid lineage, right? But please note, they are minimally differentiated, so MPO would be negative here. Okay, MPO would be negative here. M1, without maturation, myeloblast with few OR rods, MPO would be positive. M2, AML with maturation, the most common translocation is your translocation 821, rungs 1, rungs T1. More than 20% myeloblast called as AML, plus OR rods would be present. MPO would be positive, and this has the most favorable prognosis. Okay, this has the most favorable prognosis. And coming to very important from your exam point of view, M3, acute promyelocytic leukemia or APML, seen in younger patients, the characteristic translocation, your examiner's favorite question, the translocation is 1517 or PML RARA. This is the leukemia. All questions, everything that I have written in this APML, everything is a question. Seen in younger patients, translocation 1517, PML RARA fusion, associated, leukemia associated with DIC is APML. What do you see? Faggot cells. What are faggot cells? They are basically clumps of OR rods. Okay, clumps of OR rods. If you see this, they are clumps of OR rods, right? Plus the treatment, ATRA, plus arsenic trioxide, right? Now, see, a question, 60-year-old male presents with easy fatigability, recurrent bleeding from the gums, widespread ecchymotic patches, peripheral smear given below shows features of DIC, laboratory features. The peripheral smear, I have forgotten to include the peripheral smear. It is something similar to here. You will see these cells there, faggot cells. Faggot cells. So with genetic abnormality, see, they've not asked you a direct question, what is the acute myeloid leukemia type? They've asked you the genetic abnormality. So you have to identify which is the type of acute myeloid leukemia here. Bleeding from gums, DIC, ecchymotic patches, it is APML. AML, M3. So what is the genetic defect here? It is translocation 1517, right? Simple. So simple mnemonic for APML, ATRA is used. There's EML RARA fusion. You see multiple clumps of or rods. These are faggot cells. Then leukemia associated with DIC is APML. Okay. Now, coming back to the FAB classification, we studied AML, M3. M4 is acute myelomonocytic leukemia. You see myeloblast plus monoblast. There is inversion of chromosome 16, right? The genetic defect here is inversion chromosome 50. The cells are MPO positive because they are myeloblasts. Because of monoblasts, they are NSC positive also, non-specific in place, right? Coming to AML M5, it's acute monocytic leukemia, also associated with skin manifestations. That is why it is also called leukemia cutis. M5 के लिए you do the Schilling test. M5A is associated with trisomy 88. Then M5B is FLT3 mutation. It's a well-differentiated. M6 erythroleukemia associated with Guglielmi syndrome. Here you will see erythroblasts. This will be pass positivity plus MPO positivity. Okay, pass positive and MPO positive. Then M7 is acute megakaryocytic leukemia. It is the least common AML, but the deadliest one with very bad prognosis. And also, it is the most common tumor, most common leukemia in patients with Down syndrome of less than 3 years. Remember, Down syndrome less than 3 years. Can anybody tell me what is the most common leukemia in patients of Down syndrome more than 3 years? It is, yes, it is ALL. Okay. And this M7 is also associated with myelofibrosis. That is why you get a dry tap on aspiration. Because they are platelets, their platelet peroxidase will be positive. So this was about the 7 types of AML seen in your FAB classification. Please note, WHO classification is almost similar, but they play more, but they highlight more or they emphasize more on the genetic deformity rather than the type of cells present, right? So this is the immunohistochemical. We stain for MPO, chloroacetate esterase, NSC, and PAS. AML M0 to M7. MPO will be positive in all. In fact, chloroacetate esterase would also be positive in all because they are specific for myeloblasts, right? Monocytes may M4, M5 will be present in M4 and M5 monoblast, and that is why NSC will put positive here. PAS, erythroblast, and the platelets will be positive in M6 and M7, right? If they ask you which are the two leukemias, two types of AMLs that are 2-esterase positive. 2-esterase, what do I mean by 2-esterase? Chloroacetate esterase and non-specific enolase. 2-esterase positive. Which are those? They are your M4 and M5, right? M4 and M5. Okay, moving on to the next, immunophenotype. Now, if they ask you for the markers, please note the myeloid lineages markers are always CD13 and CD33. The myeloid lineage markers are always CD13 and 33. Myeloid differentiation, once the myeloid differentiation starts, MPO positivity will be there. Stem cell marker, I already told you sometime back, CD34. CD34. Then immature myeloid marker, that means they are dividing. CD117, CKIT. Immature cells, not only the myeloid cell, immature cell, these are HLA-DR. Monocytic differentiation, your CD14 and 64 will come into the picture. Megakaryocytic, 41, CD41 and CD61. Erythroid lineage, glycophorin A. Okay? Just remember, myeloid lineage, CD13 and 33 would be positive. Somebody has written that my voice is not audible. Am I audible? Rocking 360 gamer. Is my voice audible? Okay. Anybody from the Digenov team? Is my voice audible? Okay, I will continue. I'm not sure if I'm audible or not, but I will continue till the time the technical team comes back to me. Okay, so AML over, starting with ALL. ALL is the most common leukemia in children. Please note ALL, most common leukemia in children, second most common leukemia in adults, most common leukemia in Down syndrome, more than 3 years. Okay, I told you less than 3 years, it was AML N7, right? So again, for this also, we have FAB classification classified into ALL, L1, L2, L3. WHO, however, classifies this as T-cell ALL and B-cell ALL. We are going to study about the FAB classification, L1, B-cell. Corresponding classification for FAB is B-cell and T-cell ALL. Both are there. Children, usually seen in children, homozygous of good prognosis. Please note it is the lymphoblast pass positive and acid phosphatase positive. Okay, pass positive and acid phosphatase positive. L2 is seen in adults, heterogeneous. The characteristic feature that you see in smear is large nucleoli in the lymphoblast. Again, that was the pass and acid phosphatase positive. L3 ALL is also similar to Burkitt type of lymphoma, which we are going to study in a while, Burkitt lymphoma, right? Heterogeneous, prominent vacuoles, nucleoli, and it's associated with a poor prognosis. And please note the vacuolated cells that you see here are oil red O positive. Plus, they will be pass and acid phosphatase negative, but oil red O positive in Burkitt lymphoma. Okay. Now, that was FAB classification. Coming to WHO classification. B-cell ALL seen in children, and usually the bone marrow and peripheral blood are affected. However, in T-cell, adolescents and tissues are affected. What tissues? Thymus, mediastinum, testis. T-cell, remember tissues. T-cell, remember bone marrow plus peripheral blood. Okay. These are the specific genetic defects that you see in B-cell and ALL, right? Okay. Key updates in WHO classification for ALL was they've also included Philadelphia like ALL, which also has BCR-ABL fusion. But please note that this BCR-ABL is different from one which we will study in CML. Here the molecular weight is 190 kilodalton. And in CML, it is 210 kilodalton. This has a poor prognosis. This has a better prognosis. Okay, right? So, coming to Down syndrome, what are the hematological abnormalities that you see in Down syndrome? The hematological abnormalities that you see in Down syndrome, first of all, this is transient abnormal myelopoiesis. Transient abnormal myelopoiesis. This usually resolves when the patient grows, but this can also predispose to AML later in life. So they usually have AML, which type? AML M7. In patients less than 3 years, and patient more than 3 years, you have ALL, plus you also have leukemioid reactions, anemia, and thrombocytopenia in Down syndrome. These are the various hematological abnormalities that you see in Down syndrome. Okay, coming to the immunophenotypes, B cell, ALL, you will see all the positive B cell marker. That is your CD19, 10, 34. 34, remember, it's a early B cells are present, then 34 is present. Then terminal deoxytransferase positivity, cytoplasmic, IgM membrane may be also be positive. T cell ALL, remember the T cell marker 37251A TDT and 34 would be the initial progenitor cell, right? So this is the immunophenotype of B cell and ALL. Now, this was all about acute leukemias. Coming to chronic leukemias. Chronic leukemias, first of all, chronic myeloid leukemia. Okay, chronic myeloid leukemia, characteristic definition, there is identification of the clone of hematopoietic stem cell, balanced reciprocal translocation between chromosome 9 and 22. Balanced reciprocal chromosomal translocation between 9 and 22, forming the Philadelphia chromosome. So whenever you see Philadelphia chromosome positive, it is a case of CML. Okay. Normally, there's a balanced translocation. From one to place, there is a balance. Okay. So, BCR-ABL gene on chromosome 22 and ABL on chromosome 9, resulting in translocation 922. This is your Philadelphia chromosome, right? Now, Philadelphia chromosome, because of this BCR-ABL fusion gene, there is increased tyrosine kinase activity. Okay, there is increased tyrosine kinase activity. Now, what does increased tyrosine kinase activity results in? It results in inhibition of apoptosis, mitogenic activation, altered adhesion to the marrow stroma, right? Altered adhesion to the marrow stroma. And remember, this BCR-ABL gene here is 200, and the molecular weight is 210 kilodalton, resulting in increased tyrosine kinase activity. Now, the clinical features, most important, the patient will present with splenomegaly. Splenomegaly, the patient can also present with a mass in the abdomen. That could be because of splenomegaly. Or sometimes the patient will say there's a dragging sensation. Patient will present that there is something dragging inside his abdomen. There's a mass in the abdomen, and this would be splenomegaly. Very characteristic feature of your CML. Now, what do you find in juvenile CML? Juvenile CML, here the Philadelphia chromosome would be absent. Okay, Philadelphia chromosome would be absent. Your lymph node enlargement would be there. Hemorrhage would be there. Here the lab score would be normal. In CML, the lab score is reduced to normal, right? But this has a poor prognosis. What is Noonan syndrome? Noonan syndrome is basically an autosomal dominant disorder associated with craniofacial deformity, chronic heart disease, short stature. Okay. There's usually mutations in the RAS MAPK pathway and is associated with neurofibromatosis 1, right? Now, the natural history of CML, we've all studied about. It starts with there's a chronic phase, accelerated phase, blast crisis because of the increased use of tyrosine kinase inhibitors these days. There's little difficult to segregate or basically divide into these phases, but for the study purpose, we divide chronic, accelerated, blast phase. Chronic phase, there is increased number of myeloid cells. However, the blasts are less than 10%. Basophil are also less than 10%. Remember, AML, the blast more than 20%. Here, the blasts are less than 10%. Basophils are less than 10%. Myeloid cells are increased. Basically, the cells in the precursors in the myeloid lineage, your myelocyte, metamyelocyte, promyelocytes, these cells will be increased. What happens in the accelerated phase? Blast 10 to 19%, still less than 20%. Remember, basophil characteristically more than 20%. Your platelets would be reduced, anemia would be there, splenomegaly. There could be additional cytogenetic abnormality could also be present. Blast crisis. Blast crisis means the blast would be more than 20%. Okay, more than 20%. Usually there are myeloblasts only, but they are different from your myeloblast of the AML. Why? Because there would be no all rods here. Okay, myeloblast AML or rods were there, but here the or rods would not be there. Blast crisis. How will you diagnose? The peripheral smear characteristic feature that we all know about is college party appearance. College party appearance means, see, college party college mein there is no uniform, you all there's a party, you all go in different dresses, right? So everybody looks different. So this is a college party appearance. Here also all the cells, all the myeloid cells look different. You can see neutrophils, you can see promyelocytes, you can see band forms here, mature neutrophils, you see metamyelocytes, all forms of precursors in the myeloid lineage you can see. So different appearances. That is your college party appearance, right? Anemia, leukocytosis, platelets would be normal or low, and the lab score would be low. Why? Because the neutrophil count as such is low, your precursor cells are more, right? Okay, bone marrow, what do you see? Bone marrow, again, bone marrow would be hypercellular. Your myeloid erythroid ratio here would be more. Anemia is my myeloid erythroid ratio was decreased. Normal myeloid erythroid ratio is 3:1. This increases, so the ratio also increases. The characteristic feature that you see are small platelets, okay? So these are small platelets. This one, these are small platelets, right? So these are called dwarf megakaryocytes, right? And what else do you see? You see basophilia, increased number of basophils. Basophilia, even on the biopsy, you see basophils. Plus, aspirate, the characteristic cell you see is sea blue histiocytes, also known as a pseudo-Gaucher cell, because of the why sea blue histiocyte? Where do you see Gaucher cells actually? You see it in, yes, Gaucher cell is seen in lipid storage disorder. Which one? With glycosphingophospholipid accumulation, right? Okay. So there you see Gaucher cell. Here, just like crumpled cytoplasmic appearance, sea blue histiocytes, these are called pseudo-Gaucher cells. Treatment, I already told you, we have to use tyrosine kinase inhibitor. That is imatinib. Okay. Now, this was chronic myeloid leukemia. You say chronic myeloid leukemia, the cells are always dividing, right? The cells are dividing. They are multiplying lifelessly. CML, cells multiplying lifelessly. You see multiple forms of the neutrophils. You see not multiple forms, but you see the precursors of the neutrophils. They are dividing, multiplying lifelessly. Chronic lymphocytic leukemia or CLL, that is calm lymphatic leukemia. So you will see calm lymphatic leukemia. You see the cells are calm, they are not dividing. You see lymphocytes, right? So basically, it's a monoclonal proliferation of mature B lymphocytes defined by absolute lymphocyte count more than 5,000 cells per microliter. Okay, more than 5,000 cells. That's the most common leukemia in adults in West, and it is familial associated malignancy, right? So remember CLL, here the cells don't die. CML, the cells are multiplying. CLL, calm lymphatic, don't die. CML, the cells are rapidly dividing or multiplying. Now, again, you will see marked lymphocytes here, mature lymphocytes, plus the very characteristic feature, you will see smudge cells. What are smudge cells? Crushed little lymphocytes. Another mnemonic for CLL, crushed little lymphocyte. 90% of them will be mature lymphocyte, plus while the preparation, because during the preparation of the smear, you can see crushed cells or mature smudge cells. Now, 20% of the patients will have autoimmune hemolytic anemia. The triad of autoimmune hemolytic anemia, plus ITP plus CLL. What is this called? This is called Evans syndrome, right? This is called Evans syndrome. Now, that was college party appearance, CML. CLL is schoolgirls party. Schoolgirl party means all the girls are dressed in same uniform, same appearing cell, right? Same appearing mature lymphocytes, same appearance. So it is schoolgirl party appearance. And what do you see? On biopsy, basically there is replacement of the lymphoid follicles by mature small lymphocytes. Okay. And CLL transforming to diffuse large B cell lymphoma. Diffuse large B cell lymphoma. This is known as Richter's transformation. All right. This is known as Richter's transformation. Please note that these are small mature lymphocytes and smudge cell. Okay, the smudge cells. So this is the case of CLL. Now, what is the most appropriate next step in the diagnosis or in managing the first for diagnosis and then managing the patient? You have to do a flow cytometry, right? You have to do a flow cytometry. Okay. Then the megakaryocytes, the platelets. What all are the platelet abnormalities that you see? First of all, we've spoken about dwarf megakaryocytes. I just now told you where do you find dwarf megakaryocytes? You see it in CML. Now here the megakaryocytes have cloud-like nucleus. A cloud-like nucleus. Where do you see this? You see it in progressive myelofibrosis. Now here it is fawn ball nucleus in the megakaryocyte. Where do you find this? You see it in myelodysplastic syndrome. Then the megakaryocyte having a staghorn-like nucleus. Where do you see this? You see it in essential thrombocythemia. These are the characteristic megakaryocyte abnormalities that can be asked even as image-based questions, right? Now, coming to lymphoid neoplasm, initially they were divided into Hodgkin's and non-Hodgkin, right? But this classification has been revised. As per the revised WHO classification, the lymphoid neoplasms are basically with B cell predominance or T cell predominance. Now, your Hodgkin lymphoma and your plasma cell neoplasms also come under the B cell predominance lymphoid neoplasms, right? But as we had studied earlier, we study the difference between Hodgkin's and non-Hodgkin. Hodgkin's cells of origin B cell, non-Hodgkin could be B cell or T cell. Usually the lymph node affected is single axial group of lymph nodes. Here, multiple and peripheral lymph nodes. Hodgkin's lymphoma, the lymph nodes usually are cervical, mediastinal, para-aortic. Here it could be mesenteric or Waldeer. Now, lymph node involvement in Hodgkin, it is contiguous spread. That is, if this is a chain of lymph node, one lymph node be affected first, then the second, then the third. This is contiguous spread. However, in non-Hodgkin, one lymph node could spread to this, or to this. Basically, it is not in order. Hodgkin lymphoma extranodal spread is rare, while it is common in non-Hodgkin. Right? Characteristic cell that you see in Hodgkin lymphoma, I'm not sure I should be discussing this or not because you have studied n number of times. The examiner's favorite question, RS cell, Reed Sternberg cell, discovered or described by Dorothy Reed and Carl Steenberg. What is the Reed Sternberg cell? It is of cellular origin is the B lymphocyte, the B cell. The cell of origin is the B cell. And how does it appear? It's one, two, or multinucleated with a pink eosinophilic nucleolus and a perinuclear halo, right? Perinuclear halo, giving it some owl's eye appearance. Owl's eye appearance. Where do you else you see owl's eye appearance? Which nucleus? You also see it in cytomegalovirus. But there, the eyes or the nucleus is blue in color. Here it is pink eosinophilic. Pink eosinophilic with perinuclear halo. Okay, perinuclear halo. Right? Now, RSLs are also seen. I have told you Hodgkin, CMV, also seen in infectious mononucleosis, immunoblastic lymphoma, and various solid tissue tumors, right? So, okay, now if they ask you RSL, the cell of origin, it is a B cell. So, all your B cell marker would be positive, right? If I ask you CD4, CD8, or NK cell, or B cell, what is the cell of origin for Hodgkin lymphoma or for Reed-Sternberg cell? It is your B cell. All right. Now, coming to the types of RS cells, we know about the classic, the polypoid, the pleomorphic, lacunar, and mummified. Right. Very important questions that this can be asked from your for your exam is, first of all, what is the most common classical Hodgkin lymphoma? Most common classical Hodgkin lymphoma in the world. If they ask you in the world, it is nodular sclerosis. If they ask you in India, it is mixed cellularity. Okay, most common lymphoma, Hodgkin lymphoma in India is mixed cellularity. In the world is nodular sclerosis. If they ask you the classical Hodgkin lymphoma, the best prognosis in classical Hodgkin lymphoma, best prognosis in classical Hodgkin, that would be your nodular sclerosis. Or if they ask you the best prognosis overall, neither classical nor nodular lymphocytic predominant, overall best prognosis Hodgkin lymphoma is your nodular lymphocytic predominant Hodgkin lymphoma. All right. And also the most sensitive marker is your CD30. However, the most specific marker is FATS. Okay. All important questions. Mixed cellularity, most commonly seen in India. Nodular sclerosis, most commonly seen in the world. Most sensitive marker is CD30. Most specific marker is FATS5. Right? So this was about Hodgkin's. Now let's come to non-Hodgkin's. Non-Hodgkin's will study about follicular. It's the most indolent with a very good prognosis. The patient will present with generalized lymphadenopathy. The classical translocation is translocation 1418, which results in BCL2 overexpression. Okay, CD19, 20, 10 would be positive, serum immunoglobulin positive, BCL2 positive. This is best prognosis, but however, 50% of the patients will progress to diffuse large B-cell lymphoma. So follicular lymphoma, remember the translocation 1418. Okay. Now, what will you see in biopsy? You will see nodular of follicular aggregates of the lymphoma cells, right? Composed of centrocytes and centroblasts. Centrocytes and centroblasts, nodular or lymphoid aggregates, right? So follicular lymphoma, now DLBCL or diffuse large B-cell lymphoma, most common NHL. Remember, this is the most common NHL. That was the Follicular lymphoma was the best prognosis. Here it is worst prognosis. Okay. It's a rapidly enlarging mass. You usually is affected in the wall, affects the Walder ring, may arise de novo also. Remember CLL transformation to DLBCL? That was Richer's syndrome, but may arise de novo also. What is the genetic defect? BCL6, BCL2, MYC gene MYC mutation will lead to chromosomal rearrangement, BCL2 mutation, BCL6 mutation, MYC gene rearrangement, right? Now, what do you see here? You will see a diffuse pattern, diffuse large B-cell lymphoma. You will see a diffuse pattern, more anaplastic cells. You will see more anaplastic cells here. Okay, plus CD19, 20, 10, BCL6 and serum immunoglobulin positive. B-cell origin, so 19, 20 and 10 has to be positive. Serum immunoglobulin would also be positive. Now, coming to the next NHL is Burkitt lymphoma. Just now we studied, it is the ALL L3 type in the FAB classification. It is translocation 814 is the most commonly encountered translocation, the hallmark of Burkitt lymphoma. Then endemic, there are three types. Endemic involving the EBV infection. 100% of endemic cases, there would be EBV infection, most commonly seen in Africans. Sporadic also, EBV infections, but mostly seen in CNS infiltrates. Seen as CNS infiltrates. Then immunodeficiency associated can be affected anywhere, right? So Burkitt lymphoma. Will be presented with a very nice long case swelling, a long case history of the African boy, young boy from African origin, presents with jaw swelling on the bone marrow. Aspirate, you will see vacuolated cell, and on the biopsy, you see starry sky appearance. Ki67 would be 100%. That is a rapidly dividing tumor. Your answer should be Burkitt lymphoma. Okay. Your answer should be Burkitt lymphoma. African boy, jaw swelling, vacuolated cells, starry sky appearance, highly progressive, rapidly dividing tumor. It has to be Burkitt lymphoma. Starry sky appearance. What are the stars and what is the sky? We can ask you. See, the stars basically are the benign macrophages. Stars are your benign macrophages and the sky is the necrotic debris of the tumor cells, right? So this is starry sky appearance. Now coming to the next NHL, that is your mantle cell lymphoma arising from the mantle zone, the zone surrounding the germinal center. Translocation 1114. Don't worry, I will tell you how to remember all the translocations because these translocations are very important. These days, what will they give you? They'll give you a big case history and they will ask you about the genetic defect. So you will have to identify the diagnosis and then you will have to identify the genetic defect, right? So mantle cell lymphoma arising from the mantle zone, translocation 1114, which will result in overexpression of cyclin D1 and hence unchecked mitosis. This is also associated with lymphoid polyposis. CD5 positive, here it is CD23 negative. Cyclin D1 positive, SOX11 positive, right? Now, marginal zone lymphoma arising from the marginal zone, right? Nodal, marginal zone lymphoma, extranodal from the gastric mucosa. You can have gastric myeloma, which is associated with H. pylori infection. H. pylori infection does predispose to gastric meltomas, right? Here they will be CD5, 23 positive, CD5 and 23 positive, CD10 negative, right? CD10 negative. So this is marginal zone lymphoma. Now coming very important, hairy cell leukemia. Please note it is a misnomer. It is not a leukemia. It's a B cell lymphoma. predominantly seen in males in the middle age, and the genetic defect here is BRAF V600E mutation. The patients do present with splenomegaly, and please note in this lymphoma, hairy cell leukemia, the red pulp of the spleen is affected. Red pulp of the spleen is involved, whereas all the other lymphomas, white pulp is involved. And here the most common infection associated with hairy cell leukemia is Mycobacterium avium complex. Right? So you can be asked a question, which infection is most commonly associated with hairy cell leukemia? It is your MAC, Mycobacterium avium complex infection. Patients will present with pancytopenia and hairy cell, which you can easily seen under polarizing microscope. Right? Then bone marrow aspiration, we will get a dry tap. Why? Because of fibrosis. Bone marrow biopsy, what will you see? Fried egg appearance. Fried egg appearance means that is a nucleus is surrounded by a halo. This is the nucleus. This is usually surrounded by a halo, giving a fried egg appearance. Spleen, you will get beefy red spleen. The red pulp is affected here. All right. So this was hairy cell leukemia, trap positive immunophenotype. You will see CD19, 20, 11C, 25 positive. Two special stains phenotypes that we know about are annexin 1 and DBA44 positive. Okay, very quickly revising the immunophenotype. CLL or small cell lymphoma, CD5, 10, 23 positivity. Follicular में, the most characteristic finding that you have to remember, it is CD5 negative. DLBCL, BCL6 positive. Burkitt, highly rapidly dividing, Ki67 positive. Mantle cell, CD5 positive but 23 negative. Then you have cyclin D1, SOX11 positive. Marginal zone, all of them would be negative. 10, 5, 23, all of them would be negative, right? Hairy cell leukemia, your CD11C, 25, CD103, annexin 1, trap positivity and trap positive and DBA4 positive, right? DBA44 positive. All right, now, how will you remember the various translocations? So many translocations we studied. How will you remember the various translocations? Just remember bone marrow failure. Bone ka B is your Burkitt. Marrow ka M is your mantle. Failure ka F is your column. कौन सा रह गया? Marginal zone. Marginal zone sitting at the margin. So we will write in the margin B. Okay, marginal zone lymph node. So for all the translocations, all these three translocations, the common number is 14. Just remember common number 14. Ek number yaad karo. Right? Now, Burkitt B looks like what? 8. Okay. So your translocation is 8, 14. Okay. Mantle, what does this look like? 11. So your translocation 11, 14. 14 has to be common. Okay. 11, 14. Then F, fall. What does fall look like? 4. It sounds like 4. So 14 plus 4 is your 18. So your translocation 14, 18. Okay. Very quickly. Burkitt looks like 8, 8, 14. 14 common has a pin. Mantle, TL looks like 11, 11, 14. Follicular, fall, 4, 4 plus 14, 18. So it is T, 14, 18. Also in mantle, just remember mantle, the boys go mental and go cycling. Okay, no offense to boys, but the boys go mental, go cycling. So it is cycling D1 positive. But please, there is no offense to boys. Boys go mental, go cycling, right? So, cycling D1 positive. Okay, now marginal reh gaya. Remember, take the two right margins. Two right margins कौन से हैं? 11, 18. Right margins. These are your right margins. इनके margin is 11, 18. So translocation 11, 18. Okay. Marginal zone lymphoma ka 11, 18. I hope this is the way I remember the mnemonic. Probably you might have something else how to remember all these translocations. Burkitt mantle follicular margin. Right? Okay. Now, you have a 30-year-old woman presenting with multiple cervical lymph nodes. IHC is positive for CD10, BCL2. The smear shows numerous centrocyte and occasional large centroblast. So centrocyte and centroblast, what is it? It is your follicular lymphoma. Follicular lymphoma. So what would be the genetic defect here? 18 we know. So 18 ये भी हो सकता है, 18 ये भी हो सकता है. But follicular, remember, fall 4. 4 plus 14 would be your 18. So this is our translocation. Translocation 14, 18. Okay? All right. Very quickly very quickly we shall revise the translocation and the key markers in all these lymphomas. Translocation 14, 18. Follicular lymphoma, BCL2 positive, CD10 positive, you will see centroblast, centrocyte, 11, 14, that is your mantle. Just see TL looks like 11, 11, 14. Boys go mental, go cycling, cycling D1 positive, CD5 positive, but CD23 negative. 8, 14, Burkitt, B looks like 8, B looks like 8, Burkitt 8, 14, starry sky appearance, CD10, KI67. African boy, jaw swelling. Anaplastic large cell lymphoma, it's a T cell lymphoma, this translocation to 5, ALK positive, CD30, hallmark, shoe-shaped cells, cells with shoe-shaped nuclei. 821, it's your AML M2 associated with myeloblast and all rods. Inversion 16, remember AML M4E0. Okay? Associated with eosinophilia and good prognosis. 15, 17, APML, PML rara, target cells, DIC, ATRA is used for treatment. 922, CML, ALL, Philadelphia positive, molecular weight 190. Here molecular weight is 210. Here it is 190. Tyrosine kinase activity is increased and treated with imatinib. All right. Okay. So we are done with RBCs. We are done with WBCs. Very quickly, 10 minutes, we'll try to finish off plasma cell dyscrasia and then we can take a break. Okay. Plasma cell dyscrasia is basically a group of or spectrum of disorder where there is proliferation of clonal plasma cell, clonal or malignant plasma cells, right? Which produce monoclonal immunoglobulins. All right. So the first plasma cell dyscrasia, multiple myeloma, most commonly associated with bony lytic lesions. There's hypercalcemia, renal failure, immune abnormalities. Then the genetics involved the translocation 1114, T14, deletion of 13q, or overexpression of MYC plus BRAST. Then the cytokines, very important cytokine involved is IL-6. Because of this IL-6, there's myeloma cell growth and survival of the cell. Bone destruction is rankle-mediated osteoclast activation resulting in bone destruction. Plus, there is M protein, which results in renal damage, hyperviscosity, amyloidosis, and also hypercalcemia. Immune dysregulation, there's increased risk of infection. Now, this plasma cell, it produces M protein. What does this M protein do? It acts on the kidney to produce myeloma kidney. Okay. Myeloma kidney में you will see renal damage. Then on the urine, in the urine, it will produce Benz-Jones protein urea. What will it produce? Benz-Jones proteins urea. What is Benz-Jones protein urea? Basically, it's a free light chain. Free light chain. All right. And serum hyperparathyroidism. And it will result in secondary hyperparathyroidism, resulting in hypercalcemia or increased calcium level. These are the effects of your M protein. What will IL-6 do? This cytokine will activate the Rankel pathway, resulting in osteoclast activation. On the other hand, there is osteoblast inhibition by your DKK1. This will lead to bony lytic lesions. Okay. So M protein effects, you see it on kidney and hypercalcemia and Benz-Jones protein urea. IL-6 and DKK1 will lead to bony lytic lesions. Because of hypogammaglobulinemia, there will be reduced humoral immunity. All right. Now, clinical features we all know about: bone pains and osteolytic lesions, basically also called punched out lytic lesions. As if somebody has punched out the bone out of this. Punched out lytic lesions, right? Diagnosis, WHO criteria, you have to see more than 10% of plasma cells. M protein, either in the serum or the urine, IgG level should be more than 3. CRAB criteria, calcium more than 11. Renal impairment, that is creatinine more than 2. Anemia, hemoglobin less than 10, or you have a bony lytic lesion. This was the WHO criteria. Now we something have slim crab criteria. Slim crab criteria. Now what is slim crab criteria? Is crab plus one myeloma, any one myeloma defining features. What are the myeloma defining features? More than or equal to 60% of plasma cells on the bone marrow. Light chain quotients, kappa or lambda light chain quotients involved upon uninvolved. It should be more than 100. Okay, so the percentage should be more than 100. MRI, one or more focal lesion more than 5 millimeter in diameter. So this is the slim crab. Why do you call it slim crab? 60 ka S, light chains ka LI, MRI. Okay, so this is your slim crab criteria. Crab plus any one of the myeloma defining features. What else do you see? You see rouleau formation. Why rouleau formation? Because of the high level of IgG. These reduce the negative charge on the RBCs, causing them to stick together. So, rouleau formation. This is also an indicator of hyperviscosity. What do you sell? What do you see in the bone marrow? Aspirate, again, more than 10% plasma cells. Then biopsy, you will see sheets of plasma cells. Right? If you see here, sheets of plasma cells. All these are plasma cells. Right? So aspirate and biopsy, you will see plasma cells. Then there are some inclusion bodies. What are these inclusion bodies? Russell body, Dutcher body. Why do plasma cells have inclusion body? See, what is the function of plasma cell? To secrete immunoglobulins, right? To secrete immunoglobulins. Because of dysregulated synthesis of immunoglobulins, you get inclusion bodies. So first inclusion body that we have to study is Russell body. Russell body is cytoplasmic inclusion. Okay, it is a cytoplasmic inclusion. Multiple cytoplasmic inclusion will give you like a mulberry appearance. Okay, also known as Mott cells, right? Russell body, remember it's a cytoplasmic inclusion. Then we have Dutcher bodies. These are nuclear inclusions. If you see the cells here, these are nuclear inclusions. Okay. Then you have flame cell. Flame cells are usually red fiery red cytoplasm they have, and mainly associated with immunoglobulin A. Otherwise, it is immunoglobulin G, more immunoglobulin secreted. Then we have something thyrocytes. These are large flaming cells. And basically, the nucleus is pushed to the periphery. The nucleus is pushed to the periphery, right? Thyrocytes. Now, serum protein electrophoresis, very important. How is the normal electrophoresis demonstrated? What is the normal electrophoresis graph here? You get a albumin peak, then there's a small alpha 1, alpha 2, beta, and there is flattening of the graph, that is gamma. Okay, so if you see this, this is your albumin peak, this is your albumin peak, a small alpha 1, alpha 2, beta, and there is flattening of the gamma. What happens in multiple myeloma? This gamma gets elevated. So instead of this gamma gets elevated. So you will also have a gamma peak, right? Gamma peak here. You will also have a gamma peak. So on electrophoresis and immunofixation, what do you see? See, immunofixation, the light chain, particular light chain can be specified here. So if you see here, this is your kappa, this is your lambda. So here, kappa secretion, kappa chain secretion, here it is your lambda chain secretion. Both of them from immunoglobulin G. G is here, right? Gamma globulinemia. G is here. Here it is kappa, and here it is lambda chain. Okay, they did present this in the exam, and you had to identify what is the diagnosis in the urine electrophoresis. History, generalized anasarca, jaundice, hepatosplenomegaly, renal function test, deranged, urinary gamma globulin is more than 3, urine protein electrophoresis is seen here. So here, if you see a band in IgM, you see a band in IG, you see a band in kappa chains, right? Kappa region. So the diagnosis, diagnosis is multiple myeloma, but whether it is IgM or IgA or IgG, you will see a band in IgM, so it is IgM. And if they ask you about the light chain, it is kappa light chain. All right. This is how you can interpret it, the electrophoresis. Now, very quickly going to the precursors of multiple myeloma. Precursors of multiple myeloma, we know about MGUS, smoldering multiple myeloma, which can progress to multiple myeloma. MGUS means the plasma cell is less than 10%, protein is also less than 3%, and there are no CRAB features. However, in smoldering multiple myeloma, CRAB features are absent, but plasma cells increase more than 10%, M protein increase more than 3%. These can progress to multiple myeloma where CRAB features again will come into the picture, plus more than 3% M protein, more than 10% plasma cell. Please note the most common immunoglobulin found here is IgG. However, in MGUS, it is Ig. All right. So, Waldenstein macroglobulinemia, also it is IgM, lymphocytic lymphoma. IgM is found here, pleomorphic bone marrow infiltration. Again, you see monoclonal M protein, dense Jones proteinuria, and ESR is also raised. However, unlike myeloma, lymph node enlargement is there here. Hyperviscosity is also there. So here you see lymph node enlargement. And like myeloma, you also see hyperviscosity. Okay. So Waldenstein macroglobulinemia. Can we take a break for 10 minutes and we start with disorders of platelet, or should we continue? Hello everyone, we are live back again. Can we start? We just finished the WBC disorders. We will now start the platelets. Okay, platelets very quickly. I will let you know what are the tests that we do in disorders of platelets and what is the function that we measure. Platelet count, of course, as the name suggests, we measure the number of or the quantity of the platelets. Bleeding time, we assess the function of the vessels plus the platelet function also. Prothrombin time, we assess the function of extrinsic pathway and common pathway. APTT, we assess the intrinsic and the common pathway. Okay, please note that how will you learn PT is for extrinsic and APTT is for intrinsic. I hope all of you remember the coagulation cascade. Extrinsic pathway was the shorter pathway. Okay, shorter pathway. You had 3, 7, and then you came to 10. Shorter pathway. So, PT, shortening, shorter pathway. Intrinsic, intrinsic was the longer pathway. What were the factors involved in intrinsic? 12, 11, 9, 8, and then 10. All of them leading to the common pathway. 10, 5, 10, 5, 4, 2, 1. Okay. Sorry, no, 4 is not there. 10, 5, 2, and 1. The common pathway. So, extrinsic, shorter pathway, shorter name. Intrinsic, longer pathway, longer name. Okay. Then thrombin time is for fibrinogen and the common pathway. Okay. So coming to immune thrombocytopenic purpura, we all know it is acute ITP and chronic ITP. Acute ITP occurring in children. Is there history of preceding viral infection, abrupt onset, occurs within 6 months of the infection. Then you find immune complexes against the virus. Chronic ITP usually seen in adults, women of childbearing age. There's no history of infection, insidious onset, and the treatment here is steroid. This acute ITP, it usually recovers within the 6 months. Treatment here is steroids, and you will see antiplatelet antibodies here. Okay. What do you find in the lab parameters? Platelet count, of course, it will be reduced. It is thrombocytopenia. Bleeding time would be increased. Occasional large platelets can be seen, and megakaryocytes would be increased in the bone marrow. Why? Because there would be increased production of the megakaryocytes in the bone marrow because of destruction in the peripheral smear. Now, antiplatelet immunoglobulin G antibody would be positive in chronic ITP. And chronic ITP basically responds to your steroids and immunosuppressive therapy. Okay. Now, this was ITP. Coming to heparin-induced thrombocytopenia. Heparin, basically, this drug inhibits antithrombin 3. So antibodies against the platelet 4 antigen plus the heparin complex results in platelet destruction. You just need to remember the 4 T's in heparin-induced thrombocytopenia or HIT. There are 4 T's. Thrombocytopenia, thrombosis, time of fall of platelets is important. It is usually 5 to 10 days after the heparin therapy. Okay, usually 5 to 10 days after the heparin therapy, then other causes of thrombocytopenia have to be ruled out. So thrombocytopenia, because of heparin, started 5 to 10 days after heparin therapy, patient experiences thrombosis and thrombocytopenia, other causes are ruled out. Okay. So the test, again, your platelets would be reduced, bleeding time would be reduced. CT would be normal here. CT would be normal. Why? So PT would be normal. Why? Because it's acting on antithrombin. That is not a part of your extrinsic pathway. It's a part of your intrinsic pathway. So your APTT would be prolonged. And thrombin time would also be prolonged. It is acting on the thrombin, right? Now, coming to TTP. TTP, also known as Moschwitz syndrome. It's a life-threatening disease. You see thrombin in the microvasculature, resulting in thrombocytopenia, microangiopathic hemolytic anemia, and organ ischemia. The basic deficiency here is deficiency of your enzyme ADAM TS13. ADAM TS13 deficiency results. What does ADAM TS13 does? It is basically, it breaks your von Willebrand factor. So von Willebrand factor, the ultra large von Willebrand factor is present, which is thrombogenic, and it causes microthrombi. Von Willebrand factor, basically it has to be broken into small multimers for it to act. Once it is not broken, so we get ultra large von Willebrand factor, which is thrombogenic. Microthrombi are formed, which results in thrombocytopenia and microangiopathic hemolytic anemia, resulting in end organ damage. Okay. Now, we had 4 T's in heparin-induced cytopenia, thrombocytopenia. We have 5 T's in TTP. Okay, we have 5 T's in TTP. There's a thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms, renal dysfunction, and fever. This is the pentad of TTP. Thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms, renal dysfunction, and fever. Not T's, sorry, I said T's. This is pentad of TTP, 5 features, right? And how will you diagnose? You will do a gingival biopsy. You will do a gingival biopsy, and what will you see? You will see microthrombi there. You will see microthrombi there in the arterioles and capillaries, but there would be no inflammation. No inflammation. Remember, TTP, there would be no inflammation. Microthrombi would be seen in the gingival biopsy, in the arterioles, in the capillaries also. All right. Coming to hemolytic uremic syndrome, it is same as TTP only. Same as TTP, but there is a triad. What triad? MAT. Just remember MAT. You will get microangiopathic hemolytic anemia. You will get acute kidney injury. You will get thrombocytopenia. The typical HUS you would have studied in your pediatrics class also. The typical HUS, E. coli, Shiga-like toxin. Atypical, usually seen in regulation, there's a defect in regulation of complement system. Secondary HUS seen in lupus, cancer, drugs, and pregnancy. I'm not going into detail of each of these features. We've studied enough in our comprehensive lectures. But just remember, hemolytic uremic syndrome, E. coli 0157H7, and MAT, microangiopathic hemolytic anemia, acute kidney injury, and thrombocytopenia. Okay. Now, coming to defects in coagulation cascade, I already told you the intrinsic pathway, extrinsic pathway, the factors involved in intrinsic and extrinsic, as well as common pathways. So, please note, defects in coagulation, there's deep tissue bleeding, superficial bleeding, defects in vessels and platelets, deep tissue bleeding, defects in coagulation. Okay. Superficial bleeding, there could be a spontaneous purpura, petechiae. However, there could be deep tissue bleeding in defects in coagulation cascade. That is, there could be hematoma in joints, muscles, body cavities also. That is deep tissue bleeding in coagulation cascade defect. Now, a young patient presents with a large retroperitoneal hemorrhage. He also has history of recurrent knee joint swelling following strenuous exercise. So, recurrent knee joint swelling, probably deep tissue hemorrhage in the knee joint following exercise, no history of mucosal or superficial bleeding. Which of the clotting factor deficiency is most likely to be responsible? So, clotting factor deficiency most likely to be responsible here is von Willebrand factor. No, von Willebrand factor will result in superficial bleeding. Not in more of superficial bleeding, less of deep tissue bleeding. Why? Von Willebrand factor is combines. What is the role for von Willebrand factor? It helps in platelet Can anybody tell me what is the role of von Willebrand factor in hemostasis? It helps platelet adhesion. Okay, it helps in platelet adhesion. Plus, it also prolongs the half-life of factor VIII. That is why you will see superficial and deep mucosal deep bleeding, but more of superficial bleeding. Glucose anticoagulant, no. Factor 11 and 12, no. Deep tissue bleeding most likely occurs in your 8 and 9. That is your hemophilia. Okay, this is very uncommon. Hemophilia factor 8 and 9, deep tissue bleeding, right? Now, next question, which of the following tests is more reliable than individual clotting factor assay for evaluating the intrinsic pathway? I already told you intrinsic pathway, which test is more reliable than the clotting factor assay? It is longer pathway, longer name, APTT. All right, longer pathway, longer name, APTT. See, clotting factor assay is definitely the definitive test for deficiency of these factors. But apart from the clotting factor assay, the factors involved in the intrinsic pathway can be assessed by APTT, and those for the extrinsic pathway by your PT. All right. So, leading from mutation is of factor 5. Please remember this, factor 5 mutation is also leading mutation. Now, what are the vitamin K dependent factors? K dependent factors 2, 7, 9, 10. Just remember 2, 7, 9, 10. Okay, these are your vitamin K dependent factors. And because these factors are there in both intrinsic and extrinsic, so both PT and APTT would be prolonged, right? Now, coming to von Willebrand disease. Von Willebrand disease, it is the most common inherited bleeding disorders. And from where is von Willebrand factor secreted? From the Weber palate bodies. Weber palate bodies. Where are they located? In the endothelial cells. Okay, just now I told you the function of von Willebrand factor. It helps in platelet adhesion after combining with GP1B9, right? And it also prolongs the half-life of factor 8 and stabilizes it. Now, we all know von Willebrand factor is multimeric, large form. It has to be divided into smaller forms. For that, the enzyme was Adam ST30, right? I just now told you in TTP, this was the enzyme responsible for dividing the large ultra von Willebrand factor into the smaller forms. Now, we know about 3 types of von Willebrand diseases. Type 1, most common. There is partial deficiency of von Willebrand factor. That is, there is a quantitative defect, partial deficiency. Type 2, there is a qualitative defect. We have further types in type 2, 2A, 2B, 2N, 2N. 2A is there is decreased binding of the von Willebrand factor to the platelets. Here it is increased. Again, 2M, there is decreased binding. 2N, there is again poor binding to the von Willebrand factor. This is also known as pseudohemophilia, right? Type 3, there is complete absence of von Willebrand factor. So type 1 and type 3, it is a quantitative defect. Type 2, it is a qualitative defect, right? Clinical features, of course, factor 8 is involved. So deep bleeding would be there, but it is more of superficial bleeding as it involves platelet adhesion. So diagnosis, what are the blood test parameters? Bleeding time would be prolonged. Platelet would be normal here. So there's no defect in platelet. Only the platelet adhesion defect is there. That too not because of the platelet, but because of the von Willebrand factor. So the platelets would be normal. Since factor 8 is affected, so your APTT would be prolonged and your von Willebrand factor assay, if you do, it would be reduced. Treatment, we all know it is desmopressin, or you replace the von Willebrand factor or cryoprecipitate. All right. Now, von Willebrand factor prolongs factor 8. But how do you differentiate? What are the differentiating features between those? Gene on chromosome 12, This X chromosome secreted from weevil palate bodies on the endothelium, secreted from liver. Remember the vitamin K dependent factors, 8 is there. Function, platelet adhesion, plus prolongation of the factor 8 half-life. Then factor 8 itself plays an important role in the intrinsic pathway. Okay. Now, coming to hemophilia A and B. Hemophilia A is deficiency of factor 8. This is deficiency of factor 9. Right? Factor 8, factor 9. Factor 8 is there in your intrinsic pathway. APTT would be prolonged. Factor 9 also in intrinsic pathway. Your PT would also, APTT would be prolonged. Extrinsic pathway factors not involved. Bleeding time, normal. Clotting time, again, normal. Factor assay, as I already told you, deficiency of factor 8, deficiency of factor 9. Treatment, you give either cryoprecipitate or you give recombinant factor 8. Here you give fresh frozen plasma. That's rich in the clotting factors, right? Now, I'll very quickly finish up blood banking before we go to systemic pathology. I've taken only the important topics from blood banking which have usually been asked. First of all, transfusion transmitted infections. These are the transfusion transmitted infection for which screening is mandatory in India. It is hepatitis B, hepatitis C, HIV, syphilis, and malaria. All these infections mandatory, they are screened in the blood banks in India, right? Transfusion reaction, you can divide it into acute and delayed, immune mediated, non-immune mediated. In the immune mediated acute reaction, first is acute hemolytic transfusion reaction. Basically, this is due to ABO incompatibility, basically human error at the blood banking error, or could be due to an expired blood product also. Acute hemolytic transfusion reaction, then febrile non-hemolytic transfusion reaction. Here, basically, the donor WBCs react with the recipient's antibodies. Cytokines are released. How can you further avoid it? By using leuko-reduced product. By using leuko-reduced products. Okay, and transfusion related acute lung injury, which we'll study in just a while. Coming to delayed immune mediated reaction, again delayed hemolytic transfusion reaction, again due to errors. Then post transfusion purpura or transfusion associated graft versus host disease. Non-immune mediated bacterial infection, circulatory overload, transfusion associated circulatory overload, hypotension. Delayed reactions could be iron overload or contamination causing viral infections, right? Now, coming to acute hemolytic transfusion reaction, I already told you it is basically because of ABO incompatibility. ABO incompatibility usually by human error or probably due to use of expired products. You immediately stop the transfusion, you check everything, you take samples, check for the, do the blood grouping cross-matching again, and you just stop. Initial step is to stop the transfusion, right? And remove the blood banking tube. Now, febrile non-hemolytic transfusion reaction here, donor WBCs basically react with the recipient's antibodies. So cytokines are released for cause fever, chills. Treatment is you give antipyretics to and basically symptomatic treatment, and this can be avoided by using leuko-reduced products. Then allergy or anaphylaxis is basically due to allergy to plasma proteins. Okay, and how do we prevent it? By using washed products and give antihistamines. Right? Now, coming to transfusion-related acute lung injury, probably famously called TRALI. What happens here? The donor's anti-HLA antibodies. Donors' anti-HLA antibodies in the plasma reacts with the recipient's HLA antigen. present on the WBCs. Donors' anti-HLA antibodies present in the plasma react with the recipient's HLAs present on the WBCs. See, donors usually most commonly seen with transfusion with fresh frozen plasma, because fresh frozen plasma, obviously, donors' anti-HLA antibodies would be present. These two react and aggregate in the pulmonary microcirculation, resulting in increased vascular permeability. And because of this increased vascular permeability, there is acute pulmonary edema, resulting in non-cardiogenic pulmonary edema, also in adult respiratory distress syndrome and a hyaline membranous. This is also an acute reaction. Okay, acute reaction occurring within 6 hours of transfusion. All right. Now, transfusion associated circulatory overload or TACO. This is basically because of the pre-existing comorbidities. What comorbidities? Anemia usually can be seen in pregnancy, infants, elderly, or patients of acute heart failure, chronic heart failure or acute heart failure, where already the circulation is overloaded and we give blood transfusion. So there is transfusion associated circulatory overload. The patient usually present with increased blood pressure, JVP would be raised, and BNP would be raised, right? All of them would be raised, which will not be there in transfusion-related acute lung injury. This is a very important differentiating feature. JVP and BNP would be raised in TACO, but not in TRALITE, right? Now, delayed hemolytic transfusion reaction could be due to human error, where we have not checked the minor blood groups. So this could be minor blood group mismatch, or alloantibodies could have been formed in a previous transfusion, which we have not been able to detect. Then post-transfusion purpura is also a delayed reaction, could be due to antibodies against the platelets. Right? Now, transfusion-associated graft versus host disease is the same as that you have studied in transplant-associated graft versus host disease. Okay, same as transplant-associated. What do you see? You have an immunocompetent donor plus immunocompromised recipient. See, the donor T cells basically attack the immunocompromised recipient and resulting in fever, rash, hepatomegaly, and pancytopenia. Okay, so this is transfusion-associated graft versus host disease. Infections, most common cause, contamination of the blood product. Screening is very important. Iron overload, transfusion hemosiderosis. Just now we spoke when we were talking about thalassemia. Thalassemia patients usually get iron overload, secondary hemochromatosis, because of repeated multiple blood transfusion. Please note, iron overload is very difficult to attain. Why? Because 1 unit of whole blood, 1 unit of whole blood gives you around 250 milligrams of iron. Okay, so you need almost 100 units of blood for all your organs to be affected. For all your organs to be affected, you need 100 units of blood. So it is rare, but nevertheless, multiple transfusion you can see, right? Okay, very important question. A patient received 4 units of blood transfusion 2 hours ago. Now patient reports chest discomfort. Chest X-ray reveals bilateral fissural thickening. What is the most common cause? Bilateral fissural thickening, the most common cause here would be not graft versus host disease, that is not seen in 2 hours. Hypocalcemia, again, no. ABO incompatibility reaction will not present with fissural thickening. So the correct answer here is transfusion associated fluid overload or TACO. All right. So this was all about blood banking. I've very quickly covered the vacutainers, the color coding of the vacutainers, because these days NEET PG also follows some of the pattern what questions are asked in ionized set. So ionized set, very commonly they asked about the vacutainers, color coding. So I just thought in a table I'll just illustrate the anticoagulants and the uses of various color coding on in the vacutainers. Red, the anti if you see a vacutainer, it's a glass test tube. All of you who have done your internship, you must have collected the patient's blood or helped the nursing staff collect the patient's blood. You collect the blood in a vacutainer, a test tube, which has a colored top. Every vacutainer will have a different colored top. Red, the anticoagulant is a clot activator, uses serum biochemistry and serology. Then sodium citrate, light blue. Sodium citrate is in a ratio of 1:9, used in coagulation studies. Sorry, this is my mistake. This should be lavender color. Okay, lavender color. EDTA, the bread and butter of a hematologist, which you do all the hematology test here, your CBC, peripheral blood smear, blood typing, all in lavender. Green is heparin for plasma chemistry, blood gases. Then gray is your sodium chloride plus potassium oxalate for glucose, lactate, and alcohol. Then again, pink is EDTA used in blood banking. Gold is a clot activator for hormones, enzymes, and lipids. Yellow, ACD or SPS for blood culture, HLA typing. Black again has sodium citrate. Remember, light blue coagulation studies was sodium citrate, but here the ratio is 1:4. Whereas those used in coagulation tests, it is 1:9. All right. And the black is used for ESR. All right. So there's an order of draw for blood collection also. You are an intern or you are a junior resident and you've been asked to collect blood for various tests. Then what is the order that you follow for using the vacutainers? Just remember, be careful, stop, green, light, go. Okay, be careful, stop, green light, go. So B ka blood culture. C is coagulation studies. Stop means red. Stop means serum. Or what are the serum tubes we know about? Red, orange, gold. Green is heparin. L is lavender or EDTA. Go is gray. Okay, first G is green. As the name suggests, second G is gray. Be careful. Stop, red, green light, go. Even if you cannot remember these, stop for red. Okay, stop is red. Green light, go. Green is heparin, L is lavender, go is gray. All right. So this is the order in which you have to collect the blood for all the, if you have given multiple tests, right? All right. So with this, we finished the hematology section. I will start systemic right now because we don't have much time. So I will just share my screen for systemic. Just give me a minute. I'm sharing the screen. I hope my screen is visible. We'll start with the systemic. We'll go very quick because we don't have time. We just have 40 minutes. Although I had kept 1.5 hours for systemic sessions, but we'll just try to wind it up very quickly. Starting with the respiratory system. Okay, respiratory system, two most important things that you need to know about: pneumoconiosis and the lung tumors. Please do study about chronic bronchitis, asthma, the Reed index, the bronchoscopic picture of your chronic for bronchial asthma, the Kirschmann spiral and everything. Please do go through it very quickly, right? So starting with pneumoconiosis. First of all, pneumoconiosis, first pneumoconiosis that we know about is coal workers pneumoconiosis caused by coal dust. Usually the upper lobes of the lung are affected. The disorder that we call it as anthracosis, carbon pigment accumulation, anthracosis, also called black lung. Then this progresses to simple coal workers pneumoconiosis. Patients have an associated centri SNR emphysema. This progresses to progressive myelofibrosis. Progressive fibrosis basically is also, you know of something called Kaplan syndrome. What is Kaplan syndrome? Kaplan syndrome is simple coal worker pneumoconiosis plus rheumatoid arthritis plus either you can see silicosis, asbestosis. I'll just write it again. Kaplan syndrome is either coal worker pneumoconiosis or asbestosis or silicosis, plus you get rheumatoid arthritis also. So this is coal worker pneumoconiosis, carbon dust, coal dust accumulation, upper lobes. Silicosis, silica accumulation, usually seen in upper lobes. You'll be given a history of a worker in glass industry, sandstone crushing, or construction industry, which is the pneumoconiosis associated silicosis. You can please note that you need to know the occupational hazard also, which industry is it associated with. Then what do you find in silicosis? You see fibrotic nodules plus lymph node. Lymph node में what kind of calcification you see? You see fried egg calcification. Okay, fried egg calcification. And silicosis, patients are at an increased risk of infection with tuberculosis and also lung cancer. Lung cancer here is adenocarcinoma. Okay, then coming to asbestosis. Asbestosis, which industries? Mining industries, construction industries, ship repair industries, or cement factories. Asbestosis is the common pneumoconiosis seen in these industries. You will see interstitial fibrosis. Pleural disease, what all pleural disease you will see? You will see effusion. You can also see fibrosis. And you can also see plaques. But please note, in these plaques, asbestos bodies will not be there. Okay, they will not be there. Malignancy associated, it is adenocarcinoma. And the second one is mesothelioma. Okay, mesothelioma, right? Now, coal worker pneumoconiosis, the macrophages, basically they engulf the carbon pigment, right? And it is passed on to the interstitial tissue, which aggregates around the respiratory bronchiole, causing emphysema. Silicosis, the silica is toxic to the macrophage, so you see dead macrophages. Dead macrophages releasing fibrogenic factors, and this is a link. These are the lymphocyte and these are the dead macrophages, right? A silicotic nodule in your lymph node. Then asbestos body seen in asbestosis. What is asbestos bodies? Basically, they are dumbbell-shaped bodies, and iron positivity is there. Also, ferruginous, they are also known as ferruginous bodies because of the presence of iron, right? Then coal worker pneumoconiosis, you see black pigment. You see black pigment here. Then these are the macules, and you see fibrosis. Then in the silica, you see silica fibers under the polarizing microscope. Okay, only under the polarizing microscope. And this is basically your dumbbell-shaped asbestos body, right? Also seen here. See, dumbbell-shaped asbestos body, right? Now, other pneumoconiosis that we know about is berylliosis, that is caused by beryllium salt. You see granulomatous inflammation. Here, the granulomatous inflammation is non-caseating. Birefringent crystals, Schaumann or conchoid bodies or asteroid bodies, right? Byssinosis, cotton dust, hemp dust, begosis, sugarcane dust, talc, causing talcosis, or hard metal disease, cobalt or tungsten, siderosis, iron, stanosis, tin oxide dust. Okay, but there is no significant fibrosis in siderosis and stanosis. The most commonly asked pneumoconiosis are usually asbestosis, silicosis, or coal workers pneumoconiosis, right? So, question he is working in a cement industry for the past 20 years, developed mesothelioma. Very good. We have already told it is mesothelioma. So the correct answer here is, which is the pneumoconiosis associated with adenocarcinoma and mesothelioma? It is your asbestosis, right? Asbestosis. Very simple. Now let's talk about the carcinoma. Traditionally, we divide the carcinomas into small cell carcinomas and non-small cell carcinomas. Except for small cell carcinoma, all of these three fall into your non-small cell carcinomas, right? So very quickly, I'll tell you the differentiating features that are usually asked as questions in these lung cancers. Adenocarcinoma, most common cancer, most common lung cancer, most common primary lung cancer. But the most common cancer found in lungs is your metastasis. Okay. Most common cancer found in lungs is metastasis. However, adenocarcinoma is the most common primary lung cancer. Then it is seen in non-smokers. The location is peripheral. What is the genetic defect? EGFR, ALK, and KRAS mutations. Okay. And what are the markers? TTF1 positive, MUC1 positive, napsin A positive. Remember, it is TTF1 positive, and it is most common non-smokers. Females may, usually females are, mostly the females are non-smokers, so adenocarcinoma will be more important. Peripheral location. Squamous cell carcinoma, seen in males, seen in smokers. Location, central. Mutation here is P53. Okay. P63 and P40 mutation can also be seen. Small cell lung cancer, it's a neuroendocrine tumor, also known as cell tumor. Okay, oat cell tumor. It is also central in location and the genetic defect P53, RB gene mutation, or LMIC amplification. Since it's a neuroendocrine tumor, so the markers would be synaptophysin, chromogranin, bombesin, NSE positive. Also positive here is INSIM 1. What is INSIM 1? INSIM 1 is insuloma associated protein. Okay, INSIM 1 positive. This is all small cell cancer. Large cell cancers, again, more common in males, smokers, could be peripheral or central. All right, this was about all the lung cancer. Now, this is adenocarcinoma. you will basically see a glandular pattern. Okay, you will see a glandular pattern. Then squamous cell carcinoma, site concentric keratin pearls. Very important and characteristic of squamous cell carcinoma. Even anywhere else you see. Then large cell cancer, you will see, as the name suggests, you will see pleomorphic anaplastic cell, maybe irregular nuclei also. Okay. So this is the morphology, that picture of the three adenocarcinoma, squamous and small cell. Now, small cell, large cell. Now, this is small cell carcinoma. What will you see? Basically, you will see small uniform cells. And what is the characteristic feature that we describe for the nuclei? Salt and pepper. Salt and pepper appearance, not for the nuclei, but for the cytoplasmic granules, right? Cytoplasmic granules. And the cytoplasmic granules are positive for chromogranin. Wherever you see this brown stain, what is this slide? This is an immunohistochemistry slide, IHC slide. Any cell, if any IHC slide, the stain is brown colored. Please note that, right? And then you have some Azzopardi effect. What is Azzopardi effect? Azzopardi effect is basically the degenerated nuclei from the neoplastic cell. The DNA gets surrounding, the DNA gets deposited around a small blood vessel, around the small blood vessels, basically the capillary and venules. If you see a small blood vessel, the DNA will get deposited there, right? This is called Azzopardi effect seen in small cell cancer. And then you see the neurosecretory granules on electron microscopy. All right. Now, coming to paraneoplastic syndrome. What is paraneoplastic syndrome? Basically, a patient when develops signs and symptoms in a patient with malignancy, but those signs and symptoms are unrelated to that malignancy. Okay, signs and symptoms developing in a patient with malignancy, and those signs and symptoms are unrelated to that malignancy, or unrelated to that malignancy, or cannot be explained by the anatomic location of that tumor or by the hormone secreted from that tumor. So that is paraneoplastic syndrome. Paraneoplastic syndrome, basically there is either ectopic hormone production, ACTH causing Cushing syndrome, ADH causing hyponatremia, parathormone hypercalcemia, calcitonin producing hypocalcemia, gonadotropins causing gynecomactasia, serotonin associated with carcinoid. Or there could be other neuromuscular, skeletal, cutaneous, cardiovascular, or hematological abnormalities. Now, in our small lung cancers are very prone to have paraneoplastic syndromes, right? These are the most important tumors where you encounter paraneoplastic syndrome very frequently. What are the paraneoplastic syndromes that you see in adenocarcinoma? Most important, it is migratory thrombophlebitis. Okay, migratory thrombophlebitis. The squamous cell carcinoma, hypercalcemia is the most common paraneoplastic syndrome. Small cell cancer, many paraneoplastic syndromes can be seen. SIADH, Cushing's, Lambert's, Eaton myasthenic syndrome, or hypertrophic pulmonary osteoarthropathy. Okay, SIADH, Cushing's, Lambert-Eaton myasthenic syndrome. What is Lambert-Eaton myasthenic syndrome? Basically, when the patient tries to elevate his arm above his head, there is flushing because of the pressure caused by the tumor on the veins. Right. Question on the lung cancer: chronic smoker, persistent cough, significant weight loss, fatigue. There is raised serum calcium. Hypercalcemia किसमें था? Squamous cell cancer. Okay. Raised serum calcium. Lung biopsy demonstrates large atypical cell with hyperchromatic nuclei. What is the most likely diagnosis? They say large atypical hyperchromatic nuclei, don't go for large cell carcinoma. Although large cell carcinoma, we mentioned large cell neuroendocrine carcinoma just to confuse it, but seeing hypercalcemia, your diagnosis should be squamous cell cancer. Okay, not a large cell cancer, right? Okay, very quickly coming to the cardiovascular system, I am not doing acute myocardial infection. The morphology of the changes, the chronology of the morphological changes, I'm not doing that. You must have read it in your regular textbooks, in your notes. You need to remember at what time, what feature should be present, the microscopy, what should be present. I'm telling you the very important or the recently a recent update on the high sensitivity markers that can be seen in myocardial infarction, right? First of all, it is your high sensitivity troponin. High sensitivity troponin I or TI. It is a cardiac specific marker. Then it basically is raised before your, it can be detected better than your normal troponins markers, right? Then we have heart type fatty acid binding protein. It's a cytoplasmic protein and it raises 1 to 3 hours. It is raises 1 to 3 hours after the damage. It is more specific than myoglobin for early detection of MI. Carboptin is a surrogate of vasopressin. It also rises rapidly. Then we have something called ischemia modified albumin. This is also for early detection. Glycogen phosphorylases BB. It increases in ischemia before necrosis occurs. So before necrosis, just when ischemia occurs, this rises. Then we have certain genetic markers and growth differentiating factor 15, okay, which can be a marker for cardiac remodeling. Anti-inflammatory marker, right? So these can be asked, never have been asked, but the high sensitivity troponin and HFABP can be asked for early detection of MI. Please remember. Okay, rheumatic heart disease. Rheumatism licks the joint but bites the whole heart. Okay, it affects the joint, but the whole heart is also affected. We have certain environmental factors which act on the susceptible host. There is first attack of acute rheumatic fever, recurrent rheumatic fever, repeated infection or continuous infection resulting in rheumatoid heart disease. What are the immunological rheumatic heart disease? What are the immunological factors? Autoimmune reaction, cause what are the antibodies? Anti-streptolysin, anti-streptokinase, and anti-DNase. It's basically a molecular mimicry, M antigen of and the human molecule, M antigen of your streptococci and the human molecule. Revised Jones criteria. I hope all of you know what is the major criteria, what are the minor criteria, and supportive criteria. Any two major or one major plus two minor criteria. I'm sure you will be repeating this in medicine classes also. Any two major or one major plus two minor criteria. Then the characteristic features you see, first of all, RHD is what type of hypersensitivity? If we go back to yesterday's class, day before yesterday's class, RHD is what type of hypersensitivity? You see type 3 hypersensitivity reaction. Okay, type 3 hypersensitivity reaction. And the pathognomic cell you see is an Ashkoff nodule. Okay, Ashkoff nodule. And the characteristic cell that you see is Anichkov cell. Anichkov cell. It is basically a mononuclear cell with abundant cytoplasm. The nuclear in longitudinal section. The nuclear in longitudinal section is caterpillar shaped, and whereas in central section it is owl eye appearance. Okay, you have a nuclear halo giving rise to an ovular appearance, right? These cells can also become multinucleate, right? We had studied this in giant cells, type of giant cell. Then rheumatic valvulitis, see it causes pancarditis, so it affects everything. Myocardium, you see the Ashkoff nodule. Valvulitis, you see the vegetations. Vegetations are present on Vegetations are present on the upper surface of the mitral wall or the lower surface of the aortic valve, right? Atrial surface of the mitral wall and the ventricular surface of the aortic wall. And you see like a, how does it appear grossly? Fish mouth. You see, this looks like a fish mouth. Okay? Fish mouth. And these vegetations are seen along the lines of closure. Lines of closure of the valve, atrial surface of the mitral, and ventricular surface of the aortic valves. All right. Then endocarditis, also pancarditis, I told you, the myocardium is involved, the valves are involved, plus you see endocarditis. Again, in endocarditis, you will see McKellen patch. You will see McKellen patch, basically a thickened, rough patch, thickened, rough, wrinkled patch on the myocardium, on the endocardium. Then microscopically, you will see fibrinoid necrosis, fibrinoid changes, and collagen cellular infiltrates. You will also see Anichkov cells, right? Coming to pericarditis, it also causes pericarditis. What is the characteristic pericarditis feature we call? Bread and butter appearance. Bread and butter appearance. When the two layers of pericardium are separated, it looks like a bread and butter appearance, right? Then I already told you endocarditis me, you will see verrucate. You will see a McKellen patch. Then you will see Ashkoff bodies in the myocardium and bread and butter appearance in the pericardium. Okay, the extra cardiac lesions, I'm sure you're going to study in medicine. You will see polyarthritis, subcutaneous nodule, erythema marginatum. You will see rheumatic arteritis, chorea minor, and pneumonitis or pleuritis. Okay. Okay. The question that we got on this is a 35-year-old female presented with migratory arthritis. There's a pansystolic murmur, mitral regurgitation, a biopsy revealed show histopathology is shown. What is the most likely histopathological lesion? What do you see here? You see a what do you see here? You see Ashkoff bodies. Okay, Ashkoff bodies. So this is the correct answer here. Then coming to dilated cardiomyopathy. Please note that is the most common cardiomyopathy. There is dilatation. Basically, the contraction of the heart is impaired, or systolic function is impaired because the heart cannot contract. Systolic function is impaired, resulting in heart failure. Okay. The genetics, there's mutation in the TTN gene. Remember Tintin gene. It is not Tintin, it is Titin gene. Titin gene is the largest gene in the human body. It is the largest gene. Autosomal dominant inheritance. More than 20 gene mutations are seen, but the most common is Titin gene mutation. Then we have dystrophin gene also, mutation also. Then there is mitochondrial inheritance, or it could be idiopathic also. Then certain infections, toxins, metabolic disorders could be seen in peripartum or late pregnancy, autoimmune dysfunction, or please note disorder known as broken heart syndrome or Takos-Tubok cardiomyopathy. Okay, it's basically the left ventricular contractile dysfunction is there and the muscles are weak. So it is called broken heart syndrome. Okay, it's a Japanese name for fishing pot or trapping the octopus. It's a Taco-Stubo. I'm not sure how to pronounce it. It is Taco-Stubo. Taco-Stubo, right? Taco-Stubo. Broken heart syndrome. What happens? There is a myocyte injury, contractility is impaired, there is ventricular dilatation leading to wall stress and systolic heart failure. Okay. Now, if you see the right bit, the heart is enlarged. There is dilatation of all the chambers here. And you can see a thrombus also. Okay, dilatation of all the chambers and thrombus. Then you can see hypertrophy of the myocardial fibers. These are the fibers, special stains used, myocardial fibers. And you can also see ninja cells. Okay, ninja cells are basically star-shaped cells. These are your ninja cells. Whenever you see these shape of cells, your diagnosis is dilated cardiomyopathy. Okay, for dilated cardiomyopathy, you can also remember big heart. It's a biventricular dilatation, interstitial fibrosis, genetics, remember the titin gene, hypertrophy of the myocytes, ejection fraction would be reduced, arrhythmias, regurgitant valves, and thrombi would be there. So big heart for dilated cardiomyopathy, right? Okay. We also have something called arrhythmogenic cardiomyopathy, arrhythmogenic ventricular cardiomyopathy. It's autosomal dominant inheritance, and there is mutation in the genes encoding desmosome protein. Or plakoglobins, right? Desmosome protein or plakoglobins. Right. Patients usually present with sudden death. Young adults, especially athletes, they usually present with sudden death. What on biopsy, what do you see? You see a dilated right ventricle, and the entire slide is replaced by fat and fibrosis. Okay, this replacement of the myocardial cells by fat and fibrosis. Now, if you are a follower for football, in Euro 2020 football match, a player called Christian Eriksen was suddenly collapsed. Christian Eriksen. He suddenly collapsed. Thanks to the paramedicals there, CRP was given. He was later hospitalized, and ICD was installed. And the patient and the footballer is alive now. He was diagnosed for hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. Then we also have something called Naxos syndrome. In that, you have arrhythmogenic ventricular cardiomyopathy plus woolly hair plus palmoplantar keratoderma. Okay, this results in sudden cardiac death. It's an excellent inheritance. And here also, placogene, placoglobin gene is mutated and the protein affected is again desmosomes. Okay. Now, hypertrophic cardiomyopathy, I already told you, autosomal dominant inheritance. There is asymmetrical hypertrophy, hypertrophic subacute stenosis, also known as Thierry's disease, right? And how will you diagnose it? First of all, the clinical features, there's atrial fibrillation, again, sudden cardiac death, diastolic dysfunction. How will you diagnose it? How the heart is enlarged without Here there is no ventricular dilatation, without ventricular dilatation. Okay, then helter-skelter appearance. Helter-skelter appearance. That is the myocardial myocytes are arranged in a helter-skelter, haphazard manner. Myofiber disarray, right? Okay. Then I've already told you a 27 years patient dies, footballer collapses on the field and dies. Hypertrophied left ventricle. It is hypertrophy. They're not talking about the dilatation. Hypertrophied left ventricle. What is the answer here? It is your hypertrophic cardiomyopathy. All right. Now, coming to vasculitis. Vasculitis, we all know we've divided into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. The examples I've listed down: temporal, Takasayu, Borges disease. Medium vessel is polyarteritis nodosa, Kawasaki's disease. Small vessel, you see microscopic polyangiitis, you see Wegener's, you see miscellaneous. Okay. Now, P-ANCA, C-ANCA, perinuclear staining, antinuclear cytoplasmic antibodies, perinuclear or cytoplasmic. The target antigen here is MPO. Here it is proteinase 3. Associated vasculitis, microscopic polyangiitis, and here it is Wegener's granulomatosis. You see non-granulomatous inflammation in NPA. You see granulomatous inflammation, right? Okay, P-ANCA positivity, pulmonary hemorrhage, P-ANCA positivity. Lung is involved and P-ANCA positivity. So it should be MPA. Okay, microscopic polyangiitis. I hope this is clear. I'm going very fast. We have very less time. Coming to the GI in hepatobiliary system, this time we INI they had asked about Barrett's esophagus, a pre-malignant condition. What is the histological hallmark in Barrett's esophagus? Is your goblet cells. Okay, basically your goblet cell is the histological feature. It can progress to adenocarcinoma. Gold standard for diagnosis is endoscopy with biopsy, and the type of adaptation. See, even if you go to this your cell injury chapter, if you ask you what is the type of adaptation seen in Barrett's esophagus, it is metaplasia. One epithelium being replaced with another epithelium. It is reversible if the injurious stimulus is removed early. H. pylori, it's a gram-negative curved urease positive bacillus. Most common cause of chronic active gastritis can cause most common cause of infectious cause of peptic ulcer disease, also associated with intestinal type gastric adenocarcinoma, malt lymphoma, and it is not associated with diffuse but with intestinal, right? Urease is the key enzyme. Diagnosis: urease breath test. And this increases the CAG gene. CAG-A gene increases the risk of gastric cancer. VAC-A causes epithelial cell injury, right? Then the questions that can be asked: chronic gastric active gastritis is the most common manifestation, leads to increased gastrin, increased acid secretion, hence duodenal ulcer. Chronic mucosal inflammation can lead to gastric ulcer. What is the pathogenesis for gastric adenocarcinoma? Intestinal type, remember, not the diffuse type. Chronic gastritis can lead to atrophy, to intestinal metaplasia, in fact, dysplasia, and then cancer. Chronic antigenic B stimulation can lead to gastric malt lymphoma. Long-standing infection, atrophic gastritis, and intestinal metaplasia. Of course, it's a pre-malignant lesion, right? Okay. Gastric carcinoma, we all know, divided by Lauren, intestinal type, diffuse type. Intestinal type, we already studied, associated with H. pylori, and this is associated with loss of E-cadherin gene. Diffuse type, what is the most important question that can be asked? Is your signet ring cell. The nucleus is pushed towards the periphery. Nucleus pushed towards the periphery. That is the appearance of a signet ring cell. Okay. Now, intestinal type, again, it's a glandular morphology. Then metastatic spread, pouch of Douglas, what do you call? Blummershell, ovary. It is known as Krokenberg's tumor, axillary lymph node, Irish node, left supraclavicular, Virchow's node, periumbilical nodule, sister Mary Joseph nodule. Okay, very commonly asked. I'm sure you must have studied this long back. Just a quick revision, right? Now coming to GIST, most common mesenchymal tumor of the GI tract is GIST. Mesenchymal. Cell of origin, we all know interstitial cells of Kajal, stomach. Most common mutation, c-KIT, CD117 mutation, and the IFC marker also is c-KIT. Most sensitive marker is DOG1. Drug of choice, imatinib. Histological pattern, you see GIST spindle cells, right? Benign spindle cells are seen. Now, GIST, the most common marker, see, spindle cells you see in GIST also, leiomyoma, schwannoma also. GIST means the markers are CD117, DOG1, leiomyoma, descent, smooth muscle and SMA positive, schwannoma, S100 positive. Okay. Then Mentor's disease is a protein losing hypertrophic gastropathy. Then you see giant gastric rubal fold. Why? Because of the foveolar hyperplasia. Antrum is usually spared. Acid secretion is decreased. Why? Because there is loss of parietal cell. And it is associated with increased TGF alpha and TGFR activation. For children, it is usually associated with CMV infection and there is a risk of gastric adenocarcinoma. All right. Now, I hope you can study this from the PDF that we will provide you later on. And okay, coming to the primary biliary cholangitis. You see lymphocytic infiltrate here, florid duct lesion, bile duct proliferation. Polydocal cyst, these are basically congenital dilatation of the bile ducts. They cause jaundice, but not AMA associated. Talking about this question where patient presents with jaundice, pruritus, AMA positive and negative for AMA. So AMA is positive and negative for AMA. There is portal inflammation, bile duct proliferation, lymphocyte infiltration. So this is a case of primary biliary cholangitis. Primary biliary cholangitis, you saw infiltration, lymphocytic infiltration, florid duct lesion, bile duct proliferation. Polydocal cyst, these are congenital dilatation and not associated with AMA. Nodular hyperplasia, there is central stellate scar. It does not cause jaundice, pruritus, and is not positive for AMA. Even autoimmune hepatitis, positive for AMA, but not for AMA. Okay? Then, cytoplasmic chronic alcoholic patient, abdominal distension, shifting dullness, liver span is increased, liver biopsies, hepatomegaly. There are intracytoplasmic eosinophilic inclusion within the hepatocytes. So these are usually, what are these? These are your malary. And what are these made up of? These are made up of intermediate filaments. All right. So malary dank bodies, these are made up of intermediate filaments. Now, coming to thyroid gland, very quickly, I'm just going to describe the tumors. Papillary thyroid cancer, most common thyroid cancer with a good prognosis. With a good prognosis, and the etiology could be external radiation, iodine excess, most commonly BRAF V600E mutation or red PTC gene rearrangement, right? So, these days they do ask where all BRAF V600E mutations can be seen, which all cancers, which all malignancies this mutation can be seen. So just remember, most people can grow big, new, healthy lungs. Most people can grow big, new, healthy lungs. So M is melanoma. P is your papillary thyroid cancer. C is your colorectal cancer. G is your glioblastoma. B is your biliary or cholangiocarcinoma. Then N is your non-small cell lung cancer. Remember, we had studied in non-small cell lung cancer this mutation. H is for histiocytic Langerhans hairy cell leukemia. H is for hairy cell leukemia, and L is for Langerhans cell histiocytosis. Hairy cell leukemia also we have studied this mutation, right? Then microscopy, you see a papillary pattern. Please note it is a true fibrovascular core. Inside the papillary fiber, inside the core, you get a vessel also. So it's a true fibrovascular core. Then, of course, everybody's favorite question, ground glass optically clear nucleus, orphan Annie eye nucleus. Please note this is a formalin in artifact. It is not seen in FNAC, not seen in FNAC, only in formalin pit slides, right? Orphan Annie, why do we call it Orphan Annie? See, Annie was a cartoonist who forgot to draw the pupils in the cartoon character, right? So you see optically clear glass, ground glass nuclei in these papillary thyroid cancer. Then you have coffee bean like grooves, intranuclear coffee bean like grooves. Then you have intranuclear pseudo inclusions also, plus very characteristically Samoma bodies. What are Samoma bodies? These are your concentric lamellar calcified structures. And this is because of why calcium? Because of dystrophic calcification. Okay, it is not metastatic calcification, it is dystrophic calcification. Where all do you see Samoma bodies? You see in meningioma, you see in papillary cystadenocarcinoma of the ovary, chromophobe renal cell carcinoma, Samoma peritoneal carcinoma, and cholangiocarcinoma also. On FNAC, it can be confused. I'm fine. FNAC, you cannot see Samoma bodies, but on slide, you can. So it can also be confused with calcified material or thick colloid, right? Now, colloid, FNAC में papillary carcinoma में you get bubblegum colloid. It's a thick insipid colloid, right? Then coming to follicular thyroid carcinoma, the characteristic feature, if this is your vessel, this is your vessel wall, there is capsular invasion, plus there is vascular invasion. Capsular and vascular invasion cannot be seen on an FNAC. It can only be seen on your slide. Then anaplastic thyroid cancer, it's a rapidly growing mass, can arise de novo, or your papillary or follicular cancer can progress to anaplastic thyroid cancer. Then you see large pleomorphic cell. Large pleomorphic cells here. They are basically PAX8 positive and TTF1 and thyroglobulin negative. Please note PAX8 positive, TTF1 and thyroglobulin negative. Okay, then coming to medullary thyroid cancer, the cell of origin is your parafollicular or C cell. You characteristically see RET gene mutation. Sporadic, usually seen in middle or old age. Familial is seen in younger age. Multicentric or associated with men 2A, men 2B. Right? Okay. We have calcitonin. What is calcitonin? Medullary thyroid cancer secretes calcitonin. What does calcitonin cause? It secretes your amyloid A associated protein. So that is why you see Congo red stain positivity, apple green birefringence, right? See, medullary thyroid cancer, wherever you see pink amorphous material in a thyroid cancer, it's medullary amorphous thyroid cancer. All right, this will stain positive for Congo red and baffle green by refringence in Polaroid microscopy. Very quickly coming to pheochromocytoma, it's a tumor of pheochromocytes or chromaffin cells of the adrenal medulla. What is the rule of 10 seen in pheochromocytoma? 10% are malignant, 10% bilateral, 10% seen in children. Otherwise, they are more common in adults. 10% extra-adrenal, 10% patients are normotensive. Otherwise, they are hypertensive. Okay. So again, you can see the associated MEN2A, see red proto-oncogene, von Hippel-Lindau syndrome, VHL tumor suppressor gene. What do you see here? Hemangioblastoma, clear cell, renal cell carcinoma, pancreatic cyst. This has also been asked as a question in INI-SET. Von Hippel-Lindau syndrome, you see hemangioblastomas, clear cell RCC, pancreatic cyst. Then NF1 gene, Kappa-Ellis spot, neurofibroma, Lish nodules. Hereditary paraganglioma, SDHX subunits mutation. High risk for extra-adrenal paragangliomas and malignancies, right? So, pheochromocytomas, the triad characteristic, palpitation, headache, excess of sweating, diaphoresis, measure 24 hours urinary metanephrin or VMA, that is vinyl mandelic acid for diagnosis. What is the pattern that you see? Zellball pattern. What are Zellball pattern? Nested pattern. Basically, it's a German name for cell balls. Okay? German name for cell balls. This is the nested pattern see that you can see. Cell balls. Now, coming to men, very quickly, I'm telling you the types of men. We have MEN1, MEN2A, 2B, and MEN4. MEN1 also known as Wermer syndrome. Remember here, 3 Ps. You get 3 Ps. What are the 3 Ps? Parathyroid hypoplasia, pituitary tumor, pancreatic neuroendocrine tumor. Right? MEN1, Wermer syndrome. MEN2. Instead of 3 Ps, you have 2 Ps. Now one M will come in. Parathyroid hypoplasia, pheochromocytoma, medullary cancer thyroid. Then instead of 2 Ps, now there are 1 P, 2 N. Marfanoid habitus, medullary thyroid cancer, mucosal neuromas, pheochromocytoma. Okay? So your P's are reducing, M is increasing in 1, 2A, 2. When we have MEN4, we have parathyroid tumor, pituitary tumor, and gastropancreatic neuroendocrine tumor. All right. I think I can share you the PDFs of this. So at least it would be helpful because right now we have already exceeded our time and we still have a lot. If you want me to do something else, if you prefer any other system, please do let me know. Otherwise, I can share the PDFs with you, right? So we'll have a test tomorrow and day after tomorrow, we'll meet again for the discussion of the test questions. So I would take your leave for now and we'll share the PDFs with you so that at least the PDFs could be useful. At least we could not complete the sessions, the PDF would be useful. All right. So thank you so much. Have a nice evening and all the best for your exams. Thank you.